Dr. Abhijit Deshmukh. Dr. Pankaj Ingre has come from Amravati and he will be joining. He's just check-in and he will be joining shortly. And Vaibhav Banai is on his way to the hotel. So with this brief introduction, I request the chairpersons to start the proceedings and keep the time management.
Good evening, everybody. Welcome all delegates and speakers, which are those who are in the hall as well as online attendees. Though this topic looks more of a theoretical, it's clinically important, and as our speakers present the different topics, I think I am sure all of us will develop keen interest to learn more about it. So to begin with, introduction of esophageal and anorectal manometry.
Before Akshay joins, let me tell you that Akshay has done his DM in gastroenterology from the prestigious SGPGI, and he's worked about for a year doing a fellowship in motility for a period of a year with Uday Ghoshal. So he's one of the fellows who has an in-depth knowledge of motility. So we always, when there are graphs coming and the impedance and other things, we always consult him as to what is to be done. And he's another thing about Akshay is he is a very good teacher, excellent teacher. Those fellows who are with us in joining endoscopy and all, he's a great teacher. He teaches them thoroughly. Akshay, over to you.
Am I audible? Yeah. So, good evening, everybody. It gives me great pleasure to be starting this session on GI motility. Rarely touched topic, but an essential one in diagnosing and evaluating many disorders. So let me start with the basics of the very first investigation that is needed in a motility lab, the manometry. So manometry is used to examine the contractility of any luminal organ, and the pressure sensors on a manometer will detect the luminal contractions based on the pressure changes that occur inside the lumen. On the background here, you can see a typical tracing of an esophageal manometry, where you can see the upper esophageal sphincter, with, which is depicted with the upper pressure bar, and the lower pressure tracing denotes the lower esophageal sphincter. The contraction is seen as an oblique tracing along with the time lapse. So we'll start with the basic esophageal manometry. The indications include non-obstructive dysphagia, where there is no mechanical obstruction, to look for esophageal muscle function and lower esophageal sphincter relaxation in gastroesophageal reflux disease, and those who are surgical candidates for a hiatal hernia. Let me stress that this is essential point that the patients who are undergoing fundoplication for reflux or a hiatal hernia should undergo an esophageal muscle testing before they undergo surgery, lest they develop dysphagia later. Because most of these patients, especially elderly ones, will come out to have an ineffective motility, and that's why they have ineffective clearance and reflux rather than lax LES. Recurrent vomiting or belching or hiccups are also an indication to look for esophageal, to do an esophageal manometry and look for motility abnormalities or acid clearance abnormalities, as will be covered by one of our speakers later. So the normal anatomy of esophagus, everyone here is well versed with the normal structures. It's a long muscular conduit with no secretory or digestive functions, but just meant for bolus transfer to the stomach. For the bolus transfer, it is absolutely essential that a coordinated peristalsis occurs and a timely sphincter relaxation is managed along with the coordination. So the peristalsis, as shown by the schematic on the left, transfers the food bolus with successive contractions into the esophagus forward towards the LES, which then relaxes and then transfers the bolus into the stomach. These pressure readings can be denoted with a plethysmography, which is nothing but a pressure sensor, by a catheter which is introduced into the esophagus, which is the principle of manometry. So inside the manometry room, you will see a software which has the pressure tracings recorder, and a water perfuse machine, which infuses distilled water at a constant rate into the pressure sensors. On the right, you can see a transnasally inserted manometric catheter, which has openings at every 1 centimeter and will have pressure sensors over there. Whenever these openings get occluded by the esophageal muscle contraction, a pressure wave or a pressure spike is recorded in the manometric catheter and on the software. So after overnight fasting, and especially avoiding medications that will alter the LES pressure like coffee or calcium channel blockers or nitrates, the patient is instructed to come fasting to the manometry lab, and a catheter is inserted transnasally in supine position after a 60-second resting phase. After the insertion of catheter, the 10 wet swallows are given, 5 ml each, and swallows are analyzed for any abnormality. 10 wet swallows again in a secondary or upright position. This is the current Chicago 4 protocol, and 5 semi-solid swallows only for a solid state catheter. Most of the catheters that we use today are water perfusion catheters, and solid state systems only exist mostly in institutions and are mostly used for research purposes. Esophageal pressure topography is the current latest technique, and all manometry systems currently use this technique to locate all the landmarks in the manometry, which was the first slide shown. Notice the hypopharynx, which is the uppermost blue zone. It is a low pressure zone when the pharynx above the UES relaxes to receive the bolus. The UES relaxes at the edge, at the beginning of a swallow. Let me point this. So that's the UES, that's the USC relaxation. Otherwise, the UES is tonically contracted. So when the UES relaxes and it gives out a low pressure recording, then this is the striated muscle contraction. So that's the striated muscle contracting, and then it passes the bolus to the next zone, which is the smooth muscle zone, and ultimately the bolus is transferred into the stomach. And the LES, as you notice, has relaxed ever since the UES has relaxed. So this is the beginning of the swallow and end of the swallow when the LES starts contracting again. So localization of landmarks is very easy with these color recording. The previous version of a conventional manometry used to be difficult, and the LES localization and other stuff used to be difficult in conventional, where the pressure spikes were recorded, and then the patterns of peristalsis that we see nowadays were not as classical or as easy to interpret in the conventional counterpart. So the vertical bar is the length of the esophagus along which the landmarks are located, and the horizontal is the time against which the swallow event is recorded. So in a basal sequence, when the manometric catheter is inserted, notice that there is a tonically contracted upper esophageal sphincter, and it is it's not giving any alterations of pressures, whereas the lower esophageal sphincter, although it is supposed to be tonically contracted, it is giving out a pressure at a lower level every single time. And you can see these dark blue and light blue alternate colors in the basal manometry sequence. These are inspirations and expirations. So esophagus being a being an intrathoracic organ, it gives out the pressure recordings just like the thoracic cavity, which has negative pressures during inspiration and positives during expiration. So these dark blue will be inspirations, and exactly at that inspiration there will be a descent of the crural diaphragm, which is also a component of LES high pressure zone. So a crural diaphragm will descend, you will have a negative pressure. That means the patient has taken an in-breath, and at expiration, this diaphragm will come back again to be congruent with the LES. So this is the LES and CD overlap, and the CD is separating with every single inspiration. So those are inspirations and expirations. Look for unwanted pressures. So the UES at the upper zone and inspiration, which is shown by dark blue, whereas LES and CD are down at the lower end of the slide. But what are these pressure changes that keep appearing at a higher rate than respirations, because crural diaphragm is contracting with every single inspiration, but these changes are higher. So these are actually cardiac pulsations. They are appearing slightly higher than the diaphragm, and maybe one of the great vessels or the cardiac chambers themselves causing these pressure changes. You have to negate or exclude these pressure changes from your calculations. So when you give a liquid swallow, again, the UES has classically relaxed the striated muscle, and the smooth muscle has transferred the bolus into the LES. The point here to be noted is that esophageal manometry is kind of blind. It doesn't show you the bolus being transferred. It only shows you the muscular contraction, and you are supposed to quantify the muscular contractions as well as relaxations of the sphincters to look for the coordinated function of the hollow muscular organ. Whereas bolus transfer, we evaluate with either a barium swallow. This problem of needing another investigation is actually solved by solid state manometry and impedance. So liquid plus solid swallows can be given in solid state manometry. You can also give liquid swallows. It has a better resolution because it has 36 sensors instead of the usual 24. Most of the manometry systems that we use are actually an Australian company called Jeff Hubbard. It's named after the person who is the manometry professor in Royal Melbourne Hospital, Dr. Jeff Hubbard, and he has designed that catheter. That catheter only has 16 channels. So again, a lower resolution. There are catheters available water perfused with 24 and 36 channels as well. But solid state always comes in 36 channels. So always a higher resolution. Solid state is, especially for research purposes and in some institutions, is also available with 256 sensors. So a great resolution and a great detail of contractile abnormalities can be denoted by it. So selective dysmotility with solids can also be disclosed with solid state, but it needs thermal compensation, which is a software related adjustment in the pressure record. It is a high maintenance catheter. It can only do, take care of maybe around 500 manometries, and after that it either needs maintenance or either needs to be replaced, and it's costly. So these are the red ones are the red dots that you see are the impedance sensors on the solid state, and the impedance software comes inbuilt with the solid state machine. So here you can see a typical wet swallow, but the impedance software has sensed that the contents of the esophageal lumen, which alter the resistance of the esophageal lumen or the media between the sensors and the esophageal mucosa, those can be seen and traced down into the stomach. So the impedance can sense that the liquid or the wet swallow has completely cleared into the stomach, and none of the liquid swallow has remained here in the esophageal lumen later. So this kind of replaces the barium swallow, but at a huge additional cost. So that is impedance clearance. This landmark and a very basic study revealed that HRM with impedance showed that those people who were able to generate at least 30 millimeters of mercury intrabolus pressure inside the esophagus, they cleared the bolus effectively, whereas those with weak peristalsis did not. That is why we actually take a 30 millimeters of mercury pressure outline, which is supposed to be required for an adequate bolus clearance. This marked with a yellow line. This is a 30 millimeter pressure outline, and we measure all our landmarks as well as some of the manometry parameters like contractile front velocity on this line. Nowadays, contractile front velocity is no longer used, but a landmark which is used, which is called CDP, the contractile deceleration point, is still used in manometry to calculate the distal latency, and that's always been there, and that is again calculated at this 30 millimeters of mercury pressure line. So this needs to be there, and that is why we need an acceptable resolution. So in this sequence, you can see the upper esophageal sphincter relaxation, then a sequential peristalsis, and the LES has relaxed. Apart from the diaphragmatic contractions for respiration, the LES has relaxed, and we have taken 4 non-consecutive LES relaxation periods for calculating the lowest pressure. You take an average of this non-consecutive lowest pressures, and you get the IRP, the integrated relaxation pressure. This is most important for calculating the extent of relaxation of LES, and this is how you can see whether the LES is completely and successfully relaxed. So in other parameters, the most important is the distal contractile integral, where you actually see the contractility and vigor of contraction of the distal smooth muscle. You calculate it by taking a product of the length of the muscle contracting, the time taken by the muscle contracting, and the pressure generated by the muscle. So the product becomes centimeters, pressure generated is millimeters of mercury, and seconds. And the normal range is between 450 to 5,000. Anything below 450 will not be able to effectively clear the bolus. And that's why the patients will develop dysphagia and will be classified as an ineffective peristalsis. So a normal peristalsis has a distal latency. The 30 millimeter line will be at least 4.5 seconds from the initiation of the swallow, where the UE is relaxed. Adequate DCI, that means an adequate length of muscle contracted for an adequate time and generated an adequate pressure, and a normal relaxation of the LES, where the lowest pressure for an average of 4 seconds was less than 15 millimeters of mercury. So you need this much for a successful swallow. And if any of these parameters are off the mark, then we can call it an abnormal peristalsis and then classify where the abnormality lies. So here are typical demonstrations of some of the abnormalities, where you can see the LES has not relaxed at all, or rather has paradoxically contracted after the initiation of a swallow, and the muscle has not contracted at all. The esophageal muscle actually has failed to contract, and that is achalasia type 1. So a failure of relaxation and an absent contractility is achalasia type 1. The panesophageal pressurization, which is a vigorous attempt to contract and overcome the non-relaxing LES, is typified by achalasia type 2, whereas a type 3 is just a premature contraction against a non-relaxing LES. It's a premature contraction, but it is an adequate contraction. A non-adequate contraction will again be classified as achalasia type 1. So other motility disorders will include absent contractility with a normal IRP. You can see that the muscle is not contracting, although the LES is relaxing very nicely in the first slide, the first part of the slide. The second one is a premature contraction with a normal IRP. This is not achalasia. And the third one, a weak contraction. The DCI is just 200, less than 450. So an ineffective contraction. Again, the LES has relaxed beautifully. So this is one, absent contractility, no contractility and normal relaxation of LES. Distal esophageal spasm, no achalasia, because LES has relaxed. The third one was ineffective motility. These nomenclatures actually help us in treatment. Absent contractility and ineffective motility can be considered a continuum. Both of these do not have a definitive treatment as of now, and none of the treatments actually respond. There are some randomized control trials going on for these kind of abnormalities using cholinergics, and drugs like pyridostigmine, which are acetylcholinesterase inhibitors, are being tried in these motility disorders, because ultimately this is a failure of contraction. So anything that stimulates cholinergic nerves will be considered as a potential therapy. So pyridostigmine has given a good response in almost 60 patients back in SGPGI, where we are looking at the response. And people are actually developing better swallows, and but the DCI is still subnormal. Ultimate outcomes need to be published. So those are still investigational therapies. Distal esophageal spasm is supposed to be a precursor of achalasia. The distal esophageal spasm is supposed to progress to achalasia. Later, the IRP will increase and the person can be classified as achalasia type 3. But that has not been proven. Not adequate, not enough number of patients will come to you with distal esophageal spasm. Most of these will have dysphagia. Actually, the most common reason for developing distal esophageal spasm is reflux. So because of an acid reflux and esophageal muscle and mucosal irritation, they develop the spasm or inadequate and inappropriate contraction of the distal muscle, and they develop a spasm and will have reflux as well as dysphagia like symptoms. So that's why these people respond to PPI. A good, a nice approach to these patients would be to test for reflux symptoms and to test for reflux by using a pH and impedance monitoring if they have distal esophageal spasm, at least in 2 manometries. So Sometimes you get a normal motility, you get a normal, nicely coordinated peristalsis with a nice relaxation of LES, but the patient has reflux symptoms or the patient has symptoms of dysphagia and you have normal motility. Sometimes it is just a hiatus hernia, which is a large separation between the LES and the crural diaphragm. So to look for hiatus hernia, generally we prefer to do an endoscopy, and we end up finding a significant separation between the Z line and diaphragmatic pinch. But the point to be noted here is that the separation has to be examined and documented during the insertion of the scope, when the patient has not retched for 5 minutes and already displaced his Z line above the diaphragmatic pinch by retching too much. So at the insertion, if you find a significant separation, then you can call it hiatus hernia, especially if the LES is lax during endoscopy. Otherwise, for a separation and for a significant separation that causes symptoms, you need two things. One is esophageal manometry and second is reflux studies, that is pH impedance. So if you have both, then pH impedance and a manometry showing a separation would be documentative of a reflux caused by a hiatus. Otherwise, most of these patients will be going for an unnecessary surgery. These patients can be treated by a simple double dose PPI or maybe some coordinated breathing exercises, which can actually increase the tonicity of the LES and prevent the reflux. They don't actually need surgery. So another example where the motility was normal and the person—
Akshay, please, I am intervening. 20 minutes are over, which have been.
Yeah, sure. I just need another couple of minutes. So a normal motility, but the person had dysphagia. You can notice that everything is normal, but this high pressure zone inside the UES, which is supposed to be totally relaxing. So this is the normal, and this is the patient's hypertensive UES, and this was because of a cricopharyngeal bar. So smallest of the signs need to be picked up. This is a complicated, seemingly complicated, but very simplified version of the Chicago classification. And keeping it in for reference always at hand will always help you in correctly naming the or correctly diagnosing the esophageal motility abnormalities. The take-home message should be a thorough history and investigation and accurate interpretation of manometry, and it should be corroborated by endoscopy and FLIP and TB findings, barium esophagogram. Generally, we don't use FLIP in our clinical setup, but these are the. So anorectal manometry mostly comes, I'm overshooting my time, so I'll run through the slides. Anorectal manometry mostly comes in use for dysenergic defecation, which comes with the symptoms of either obstruction, prolonged defecation, and hard stools, and no response to fiber stimulants. That's the indication to do this. And the water perfused catheter remains the same. The resting phase shows a hypertensive zone of the external anal sphincter, and the squeeze, which is a voluntary squeeze, shows the high pressure zone being augmented by the patient's voluntary contraction. The rectoanal inhibitory reflex is the important parameter, which actually diagnoses Hirschsprung and is not much useful in adults unless they have constipation since childhood. If you inflate the balloon, which is attached to the end of the catheter, and you don't have a relaxation of the sphincter in response to that rectal distension, then the rectoanal inhibitory reflex is supposed to be absent, and that's diagnostic of Hirschsprung's. But still, you need the gold standard biopsy and ganglionosis. So the last slide, dysenergia is typified by an absence of coordination between rectal contraction and the sphincter relaxation. So dysenergia can be of 4 types, but mostly there is a paradoxical contraction of the anal sphincter against a rectal contraction, and the person is not able to evacuate because there is no proper coordination, and that is what we remove, or that is what we take care of during biofeedback. So in biofeedback, we train the person to relax adequately in a coordinated manner against the rectal contraction, and it is an acquired training or behavioral therapy or cognitive therapy sort of thing, whereas which might require repeated sessions of training, and the person ultimately gets trained to relax and then successfully evacuate. So these are the 2 main indications of manometry, the most accessible organs, the rectum and the esophagus. Antroduodenal and other manometries exist, but are not clinically useful, or rather to be clinically impractical. So that's why I've not discussed them here. Maybe if at all we start them at Nagpur, I'll be interested in talking them. So thank you.
Excellent lecture, Akshay. Akshay, when you look for the RAIR, what volume of saline you infuse into the balloon?
So that is a good question, sir. Thank you very much. The protocols are in place, but not guidelines. The London classification, which has come in maybe a couple of years ago, it says about 50 to 60 ml of water to be normal saline to be infused inside the rectum. But it also depends on the rectal sensitivity. The rectal sensitivity is also one of the parameters tested in anorectal manometry, where you infuse progressively higher amounts of normal saline into the balloon and see where the person gets the first sensation of distension, urge to defecate, and then pain. You stop at pain. And normally these values are about 100 cc's where they will get first sensation and urge, and about 120 cc's, they will feel painful rectal distension. Right. If a person develops chronic constipation, his rectum will always be occupied by stools and will be desensitized. So these values go higher. And in Hirschsprungs, where the RAIR is actually absent, these values are actually higher. So 50 to 60 is okay for small children or maybe adolescents, but for adults, it can go up to 100. But even if after 100, 120, if the RAIR is completely absent, then you can say that RAIR is effectively absent. But of course, that's not the gold standard. The gold standard is always a ganglionosis and biopsy.
Akshay, nice lecture. How do you differentiate jackhammer versus achillesia type 3? Because the graph appears to be like more or less similar, you know.
I've kept the Chicago classification in a smaller slide, but you can see on the right column, which it's not being shown. Hypercontractile esophagus is a term that has replaced jackhammer and nutcracker esophagus now. So in Chicago 4, you use only hypercontractile esophagus for any DCI more than 8,000 and any contraction which is exceeding 8,000. So you differentiate between achillesia type 3 and jackhammer by IRP. If the non-relaxation is present and a premature contraction is present, it is achillesia type 3. It needs to be present in at least 20% of the swallows, and the DCI needs to be normal. You can have a jackhammer morphology of the swallow where the esophagus undergoes repeated tertiary contractions, and those are seen like jackhammers or like a corkscrew on the manometry as well, because repeated spikes will be seen in the color graph. So that is jackhammer. Corkscrew appearance is classically seen in the barium, but currently we classify all of these as hypercontractile esophagus. And if the IRP is high, it is achillesia. If the IRP is normal, it is hypercontractile.
Yeah, nice talk, Akshay. You said that the squeeze pressure is external anal sphincter pressure,
No.
and during
Resting.
yeah, inhibitory reflex, you are checking the internal sphincter relaxation.
Yes.
So on the graph, how do you distinguish between these two sphincters?
Actually, the pressure which is recorded as a constant zone is contributed by both internal as well as external. So there is no hiatus hernia like phenomenon where the two sphincters are separated in the rectum, in the rectal junction. So 80% of the pressure which is recorded on the manometry is always contributed by the internal Allen sphincter. So when internal Allen sphincter relaxes as a reflex, it is a local spinal reflex. When the rectum distends, then a spinal reflex is thrown off and the internal anal sphincter relaxes first. So most of the pressure is given away. That is why when the internal relaxes, you have sudden significant decrease in pressure.
So on the same bar, you see squeeze pressures as well as the relaxation during
on the same bar,
RAIR.
Yes. Yeah, that's a very pertinent question. So whom do you do manometry for? So that's the question. So a person with dysphagia, a person with esophageal symptoms, non-cardiac chest pain, non-obstructive dysphagia, or a person with repeated reflux symptoms which are not responding to PPIs. That's an indication for an esophageal manometry. So a person is having reflux or is having an inadequate transfer of bolus is an indication for looking for the esophageal muscle function. So most of the times ineffective motility and absent contractility are diagnosed as an incidental finding because we are testing these people for reflux symptoms. or we are testing these people for dysphagia, and you find that the esophagus is not contracting at all, or is contracting weaker than it is supposed to be. So that time, generally, you don't have a classical symptom which is attributable to ineffective motility. Like achalasia will always come with dysphagia, but ineffective motility may not come that way, and it is under recognized as well as under diagnosed. That is why we need to be having a high index of suspicion, especially in elderly people, diabetics, chronic kidney disease patients. All of these people can have, especially connective tissue. So everybody has heard and maybe seen scleroderma esophagus in connective tissue diseases. So mixed connective tissue disease, scleroderma, whether it is limited or diffuse systemic sclerosis, will have a scleroderma esophagus where the LES will be totally relaxed or rather hypotensive, and the muscle is not contracting, and DCI is severely low. That is why the person develops dysphagia. So it is a reverse of achalasia in a way. So LES relaxes or is always hypotensive, and the muscle doesn't contract. So that's scleroderma esophagus. So these kind of abnormalities get diagnosed only if you look for them.
Many patients with ineffective esophageal motility have GERD-like symptoms because esophagus is not clearing. So they actually present with reflux-like symptoms, and on manometry we do get ineffective esophageal motility. That is very, very common presentation.
Many times prior to fundoplication, pre-operative, we pick up this ineffective motility and then advise against fundoplication. He's already said that.
We had a patient who presented as achalasia. She had holdup of barium. She was middle-aged and she had dysphagia since 6 months. We dilated her because we do pneumatic dilation of these patients instead of POEM or Heller's myotomy at our center, especially in our team in SGPGI. So we dilated her, and later she came back with a recurrence, and the recurrence was too early. Within a couple of months, maybe, I don't exactly remember the timeline, but the recurrence was too early, and she had not lost a lot of weight despite having symptoms for a few months or maybe a few years to begin with. So this was kind of odd. We took a biopsy next time because we saw some trachealization of the esophagus and it came out to be eosinophilic esophagitis. So that's a case report we have published. So they always present with dysphagia, and for them to develop strictures actually takes long time. So they can have achalasia-like picture, or their manometry can have maybe an obstructive or a DES-like picture. But currently we don't have too many eosinophilic esophagitis patients, and it would be very interesting to see what are the manometric findings in them.
Sir, I did esophageal manometry for 2 patients with eosinophilic esophagitis who had dysphagia, but surprisingly, manometry was absolutely normal. Presumably, the disease is limited to the mucosa and may not be involving the muscle layer. But I could not explain why those patients were complaining of dysphagia, though it was not a very prominent symptom.
Maybe a normal esophageal manometry or a normal muscular function could be a predictor of a good response to steroids or other drugs in eosinophilic. Whereas the patient who presented to us with achalasia, she had classical panesophageal pressurizations. So that is why we treated her like achalasia instead of, we did not even suspect eosinophilic in the first go, and we dilated her, and later she developed a stricture. We have another patient, another such patient in our follow-up, but the diagnosis has not been established yet.
Akshay, there are 2 online questions, one by Dr. Helal. He's asking whether the settings of manometry in children and adults are same or different. And there's one more question by Dr. Das, and he's asked about recommendation of balloon volume for children for RAIR in HD. I think you have answered that already.
Yes. So rectal sensitivity is the main predictor of the balloon inflation that you decide. So in children, you can actually go up to 80, not more than that, because generally their rectal cavities are small. But that depends whether the children are above or below 10 years of age, because after adolescence, the rectum almost always assumes an adult size, and it is almost always already dilated and become huge omega rectum in Hirschsprung's because of chronic constipation. Coming to the prior question, there are no fixed guidelines for the volume of the balloon, that you should not go above this. If the person is not getting a distension or a sensation, then you could go above this, and because of rectal hyposensitivity, which comes into play, the balloon volumes always get altered even in adults. And for esophageal manometry, the landmarks as well as the catheters are different for pediatric people.
Thank you, Akshay. Now it's time to move on. Thanks for your nice lecture. The next topic is to be taken by Dr. Rajesh Sainani. I will have a brief introduction to Rajesh. He is a practicing gastroenterologist at Jastok at Bhatia and his own clinic. And he has a keen interest in gastrointestinal motility. He is a fellow from Royal Melbourne Hospital, Australia. And he is a faculty and authority for motility and in various national conferences. So Rajesh, welcome to this CME, and your topic is approach to non-obstructive dysphagia.
Yeah, good evening, everyone. Pleasure to see all of you. I can see some good friends who are up so late in the night to listen to us talk. So I'll be talking today on approach to non-obstructive dysphagia. Can you hear me, sir? Yeah. So how do we define dysphagia? It comes from the Greek word dys, that is difficulty, and phagia is to eat. It's a subjective sensation of difficulty or abnormality of swallowing, and it is always an alarm symptom. In elderly patients, dysphagia should not be attributed to normal aging, since aging causes only mild esophageal dysmotility and it is rarely symptomatic. So if a patient has dysphagia, please investigate, do not treat empirically. So when you approach a patient to dysphagia, you want to differentiate whether there is oropharyngeal or esophageal. In oropharyngeal, they usually complain of a difficulty in initiating a swallow with nasal regurgitation, coughing, or choking. While in esophageal dysphagia, there is a sensation of the food getting stuck seconds after initiating the swallow. The common causes of oropharyngeal dysphagia: neurological, stroke, Parkinson's, dementia; structural can be Zenker's diverticulum; and myopathic, myasthenia gravis or polymyositis. In esophageal dysphagia, the mechanical lesions are intrinsic, like the stricture, tumor, a ring, Schatzki's ring, or a web, or extrinsic can be an organ or an aberrant subclavian artery, or a developmental abnormality, a mediastinal mass, or lymph nodes. But what we are going to focus today is on the motility disorders which cause esophageal dysphagia, like achalasia, distal spasm, ineffective motility, jackhammer esophagus, and what happens in scleroderma, as we were discussing just now, and functional dysphagia. So when you see a patient with esophageal dysphagia, the question you have to ask, is it dysphagia only to solids or with solids and liquids? And if you say it's only dysphagia with solids, then you go to the left hand of the screen where it is probably structural. And if this dysphagia is intermittent, occurs on a few days and doesn't occur on a few days, then more likely that this is because of esophageal webs, rings, or eosinophilic esophagitis. But if it's a progressive dysphagia and it is associated with chronic heartburn, you should think, does this patient have a peptic stricture or reflux esophagitis? And if it's rapidly progressive with ongoing weight loss and cachexia, then definitely cancer must be suspected. If patients present with both solids and liquids, it's probably dysmotility. And if these symptoms of dysphagia are intermittent and with chest pain, you probably have a spastic esophagus like distal esophageal spasm or the jackhammer esophagus. While if the dysphagia is progressive to solids and liquids and associated with chronic heartburn, is it scleroderma? Is it ineffective or absent motility? And if it is associated with regurgitation, then you must think, are we dealing with a case of achalasia? Now let's go through each of these as we go through the talk. So gastroesophageal reflux disease is one of the commonest causes of dysphagia that we see in our clinical practice. They commonly have heartburn or regurgitation. And we know there are two types of reflux disease: non-erosive reflux disease and erosive reflux disease, and both cause dysphagia. This is an example of erosive esophagitis, which can cause dysphagia. You have linear ulcers larger than 5 millimeters. Along the length of the lower esophagus, there is a small hernia in this patient also. But if you have somebody with non-erosive esophagus, then what do you do? So in a non-erosive esophagus, you need to confirm the diagnosis of reflux, as Dr. Akshay just mentioned. So how do you do that? You can do that by a 24-hour manometry study. Sorry, a 24-hour pH study. We do a manometry before the pH study to localize the lower esophageal sphincter. We do the manometry to assess esophageal function and the lower esophageal sphincter pressures. In this patient, the lower esophageal sphincter pressures are very low. It is hypotensive, and you can see that it's a very poor peristalsis. This is an ineffective motility. And what happens in the 24-hour pH? In the 24-hour pH, this black line in the center is the value 4. So all the dips in the pH below 4 are the reflux episode. So you place a thin antimony tube 5 centimeters above the lower esophageal sphincter, and you keep it in for 24 hours, and the patient marks all the symptoms that they have in these 24 hours. These arrows on the top are the marks for these symptoms that the patient had. So in this patient, you have a patient with significant reflux with good symptom correlation. As per the latest Lyons classification, the total acid exposure time, if in 24 hours is more than 6%, with a symptom index of more than 50% or a symptom associated probability of more than 95%, you say that this patient has gastroesophageal reflux disease with a good symptom correlation. So how do you treat dysphagia in a patient with reflux disease? Yes, you can do diet modification, but usually proton pump inhibitors twice a day for a prolonged period, for maybe 12 weeks or longer, usually helps to improve the dysphagia in GERD. Is there a role of prokinetics? No, unless the patient has associated gastroparesis and you want to help improve gastric emptying. Otherwise, per se, prokinetics don't help the esophageal motility. What if the patient is being sent for a laparoscopic fundoplication? This question was also discussed. That's why we need to know the motility of the esophagus before we send a patient with GERD for surgery. Because if they have a poor motility, then the surgeon needs to do a toupee wrap, a 270 degrees instead of a 360 degrees to prevent post-operative dysphagia. Coming now to achalasia, patients presents with dysphagia to solids and liquids. It's usually progressive. It may be associated with chest pain and heartburn. The barium can be normal, can be dilated, or the classical beak-like appearance. Endoscopies can also be normal if sent early or dilated. But in the classical case, we will have a dilated esophagus with secretions or food residue in the body of the esophagus with a resistance to the passage of the endoscope when it crosses the esophagogastric junction. So Akshay told us about the 3 types of achalasia. The type A achalasia is where the IRP is raised, that is the lower esophageal sphincter is not relaxing. There are failed peristalsis. You can see there is no wave-like peristalsis, and there is absent pan-esophageal pressurization. Achalasia type 1s will usually be the larger dilated or sigmoid esophagus with almost no action of the longitudinal muscle. In achalasia type 2, you will, besides the non-relaxing lower esophageal sphincter that tells us by the raised IRP or the integrated relaxation pressure, you have pan-esophageal pressurization in at least 20% of the swallows to say it is type 2 achalasia. In type 3, there is a spastic contraction with premature peristalsis and a non-relaxing lower esophageal sphincter or a sphincter with a raised IRP. So how do you decide which is the optimum treatment in a patient of achalasia? If you have a type 1 achalasia, the way to go is either laparoscopic myotomy or POEM. If it's a type 2, pneumatic dilatation or laparoscopic myotomy are equally efficacious. And in type 3, the response to therapy is poor. Most patients are now subjected to a POEM. Botox and drugs are very poorly effective, especially the drugs. Botox still works for a short duration of a few months, but it needs to be repeated, and it is done only in patients who are unfit for myotomy or pneumatic dilatation. Coming to esophagogastric junction obstruction, these patients present with dysphagia, chest pain. What you need to do is you need to exclude a malignancy or infiltrative lesion with imaging, endoscopy, and even endosonography. In EJG obstruction, there will be a peristalsis, but what will be different will be the raised intrabolus pressure. And because of this raised intrabolus pressure, there may be an associated raised increased IRP, and that's why there is obstruction of the food bolus. As per the Chicago 4 classification, you cannot diagnose an esophagogastric junction obstruction only in the supine position. The findings have to be seen in both supine and upright, and preferably along with an imaging technique such as barium, such as a timed barium esophagogram. So how do you treat patients with EJG obstruction? If you find a benign or malignant lesion, then you need to treat them. But otherwise, the goal is the same like that of achalasia. The aim is to reduce the lower esophageal sphincter pressures, and you can do Botox or pneumatic dilatation, laparoscopic myotomy, or POEM. So coming now to the hypercontractile esophagus, that is distal esophageal spasm and jackhammer esophagus, they present with dysphagia, chest pain, and regurgitation. The barium usually shows a corkscrew esophagus with tertiary contractions, while the endoscopy is frequently normal. In a distal esophageal spasm, you have the distal latency, that is the time from where the UES contracts till the CDP, as Akshay said. This is less than 4.5 seconds. This is what is it telling us? It is basically telling us that the middle and the lower third of the esophagus is contracting simultaneously. And that's why it's a distal esophageal spasm. And here you should note that the lower esophageal sphincter relaxes normally. In hypercontractile esophagus, someone was asking what is the difference between jackhammer esophagus and achalasia type 3. In jackhammer esophagus, the IRP will be normal. You can see here that the lower esophageal sphincter is contracting. And what happens to the distal contractile integral? It's so high, it's 19,000 in this patient. You need at least 2 swallows with a DCI of more than 8,000 with a normal IRP to call it jackhammer. There are certain overlaps. This is the classic variant. There are certain overlaps of jackhammer in which you may have a distal spasm and a jackhammer both combined, or you may have a jackhammer with a predominant lower esophageal sphincter spasm. Sorry, that's more in a distal, in a DES. So how do you treat hypercontractile esophagus? The goal is to treat the symptoms. Proton pump inhibitors twice a day. For the chest pain, peppermint oil, diltiazem, sildenafil, nitroglycerine, or isosorbide should be used. If the patient has associated visceral hypersensitivity, please add amitriptyline. And only if the drugs do not work, then you try botulinum toxin and POEM and esophagomyotomy. Many people are now doing POEM directly for these hypercontractile, and that is not required. They most commonly do respond to drug therapy. Scleroderma, they may have associated other symptoms such as reduced mouth opening, xerostomia, but the main esophageal symptoms would be heartburn, regurgitation, and dysphagia. And this is how the barium of a scleroderma may look. It gets confusing with achalasia, but usually they will empty easily. And what do you get in manometry? You get peristalsis in the upper third of the esophagus, which is skeletal muscle, but you have absent peristalsis in the lower 2/3 of the esophagus with a very low or a hypotensive lower esophageal sphincter. As per Chicago 4, these peristalsis would be called as failed or absent peristalsis if present in all the 10 swallows. The therapy for scleroderma is treat the complications of reflux, give proton pump inhibitors to prevent strictures, and look for reversible causes of myopathy. CPK may be elevated, and then these patients have a myositis element, and they may need prednisolone or immunomodulators under guidance of our rheumatology colleagues. We see anatomical abnormalities causing dysphagia, such as a double aortic arch or a ligamentum arteriosum. But what we have seen occasionally is an aberrant red subclavian artery. It is usually diagnosed by CT or EUS, and we had the rare occasion of doing one manometry in such patient, where you can see this high pressure band at the upper end, which was contributing to the dysphagia. What is the treatment? Rarely they require repair. Most of them are asymptomatic through their life and they develop symptoms in older age. Usually diet modification and reassurance helps these patients. Myasthenia gravis is a common example of dysphagia, which we tend to forget because we think we are endoscopists only and this doesn't come in our purview. But if you have a patient of dysphagia with normal endoscopy, normal barium, you've treated him for reflux, you've no reflux on a 24-hour pH, the manometry is normal, the CT scan is normal, you must think out of the box and think whether this patient has a neurological disorder, look for an expressionless face. But more commonly, these are the patients with minimal symptoms, and what they have is basically fatigable chewing, dysphagia, proximal muscle weakness, more fatigue in the evening time than morning time. And that's where you get the hint. Please note, esophageal monitoring is not routinely recommended in patients of myasthenia. There are no characteristic findings which are seen in all patients of myasthenia. This was one patient of myasthenia which was retrospectively diagnosed, where we found absent peristalsis in the skeletal muscle. So no peristalsis in the upper third, while present peristalsis in the lower 2/3. And retrospectively, when myasthenia was diagnosed, we felt that his dysmotility of the upper third was because of myasthenia gravis. But this finding is not present in all patients of myasthenia. Eosinophilic esophagitis present with dysphagia, heartburn, regurgitation, food impaction, may have associated atopy. They may have raised IgE or peripheral eosinophilia. The endoscopy commonly shows linear furrows, circular rings, proximal strictures, and the biopsy will usually have more than 15 eosinophils per high power field. The treatment is PPI again. Please use twice daily PPI. Follow the 6-food elimination diet. Avoid cow milk, protein, soya, wheat, egg, peanut, and seafood. And if this does not work, then you have an option to use fluticasone spray or budesonide slurry or a prednisolone slurry. Functional dysphagia is a condition in which patients have dysphagia, but no evidence of any mucosal lesion, no GRD, no eosinophilic esophagitis, and you've ruled out a motor disorder by manometry. The symptoms are intermittent, and the treatment is reassure the patient, avoid the trigger foods. You can try calcium channel blockers and tricyclic antidepressants, and rarely Savry-Gillard dilatation has been used, but they commonly relapse. So my last slide in conclusion, dysphagia is an alarm symptom. Always investigate dysphagia patients. Do not give empiric treatment. Endoscopy is preferred over barium. Esophageal manometry helps rule out achalasia or a spastic disorder. Once you find the cause, treat the specific cause. Thank you for a pleasant hearing.
Thank you, Rajesh. It was very simple but comprehensive and very fluid and presentation. Very nicely covered. Any top questions from the audience? We have two, three questions from the online also. We will take up that also. Look.
So should I take up the online questions? Some have already asked, in a case of ineffective motility and reflux symptoms, if they have not improved with PPI and prokinetic, is there any role of surgery or endoscopic intervention in to increase the LOS pressure? So if patient has symptoms but has not improved with PPI, these are the people who will not do well with surgery, in fact. But if you should prove whether this patient has reflux or not. So you need to do a 24-hour pH study. And if it is normal, then they have what is called functional heartburn. But if they have a few episodes of reflux, which is in the physiological range, then you call this as reflux hypersensitivity, and you should treat them with drugs like, amitriptyline. The next question is how to approach a patient with high IRP and DCI of more than 8,000. So, well, like I told you, some of them have a RAP. Some of them may have a mixed picture of both distal spasm and a jackhammer esophagus. That's when they will have these findings, because there's a very small area to calculate your IRP. But if they truly have a IRP which is significantly high in both positions, in upright and in supine, and on barium imaging, you feel that there is a holdup of the barium at the G junction, then this is more like a EJG obstruction and should be treated like an EJG obstruction. The next question, if patients do not respond to PPI with normal UGI, should we go for manometry and pH and both? Yes, we should go for both if you want the answer as to why they are still having their reflux symptoms.
Rajesh, I would like to ask, would you do a manometry to know the effectiveness of your treatment of her achalasia? Would it help?
No, so commonly we don't ask a manometry unless the patient has symptoms. So when the patients come for follow-up, unless you're doing a study, I see no rationale in asking. If they are able to eat, they don't have dysphagia. If they're not having any symptoms, you don't have to document the effectiveness of your dilatation or your treatment. I personally don't ask.
Rajesh.
Yes, sir.
Wonderful lecture.
Thank you, sir.
I want to ask what is the natural history of these patients with EGJ obstruction, weak peristalsis or impaired peristalsis? Have they been followed up, and what happens to them?
So, sir, the patients with weak or ineffective peristalsis, some of them who undergo, I should not say all of them, some of them who undergo either laparoscopic fundoplication or are on long-term PPI, when we have had to do a repeat manometry after a year or two, we do see an improvement in the esophageal motility, while some of them just continue to remain ineffective motility. We have seen patients of distal esophageal spasm whom we diagnosed initially, and then after over 3 years, they have evolved into achalasia. So sometimes some of them evolve absent contractility evolving into achalasia over a year. So that's why if you see in the Chicago, there's a recommendation that if you have a patient with absent contractility and dysphagia, you should do provocative tests to make sure that you're not missing an achalasia, and you should follow up these patients closely, because they, if the achalasia may get unmasked.
Hi Rajesh, nice talk. Prashant here.
Hi, thank you.
Hi. If you are unable to cross the LES with your manometric catheter in a patient with achalasia, what are the techniques? And if you still don't cross, can you still do any worthwhile analysis?
Yeah, so if we can't place it in the upright position, then I will try right lateral, supine, and left lateral. We try to, when the catheter is down into the esophagus, you try to twist it, circumferentially, and sometimes it coils, takes a U, like it takes like a circle and goes back in. Sometimes we are able to succeed and sometimes we are not. So I can say maybe once in every 3 to 6 months, we cannot pass the catheter. In the earlier days, we used to go in with the endoscope and try to hold the lower end, but it's very risky because we almost punctured a catheter once, and these catheters are very frightfully expensive. So we just let it be. I just call up the referring doctor and I tell them that, you have the barium, you have the endoscopy. These are usually the people who have a sigmoid esophagus, where when we know that even when we go on endoscopy, we first go on one side and then we literally have to take a turn on the other side to enter into the stomach. So we just tell them to treat it with the findings that they have. We've done it for so many years, and I don't think there's anything wrong in that. And if you do a manometry, all you can diagnose, see, it's very difficult in a water perfusion system that if you have a catheter in the body to measure the esophageal pressures, because in a water perfusion system, the esophageal pressures are based on the last channel. So the referencing channel is the last channel which should be in the stomach. And if the last channel of yours is itself in the esophagus, you're not really giving them any worthwhile information. But you can just give them a few swallows and you can make sure that there are no, major peristalsis. So you can say that there's absent peristalsis or failed peristalsis, but you can't give them a definite report.
Sir, my question is regarding eosinophilic esophagitis. In patients of eosinophilic esophagitis, have you found any abnormalities in esophageal manometry?
No, like Vaibhav said, that first we see very few of them, extremely rarely. But I've been referred a few and I think they were all normal. So we've not really seen this motility in patients with eosinophilic.
Rajesh sir, Abhijit here. In our practice, we see a lot of patients with posterior circulation stroke who are otherwise very normal, but they have a very bad disability of inability to swallow. So in your experience, is there any role of doing an early manometry in these patients, and any role of doing one-time SG dilatation or something, or Botox?
No, nothing, no. These people with posterior circulation stroke, there's no role of manometry at all. I think they need to be sent to a speech pathologist. The speech pathologist here do what is called a modified swallow, where they do a swallow mixed with barium of different consistencies. So they do it of liquid consistency, honey, then a little thicker one, like first liquid, honey consistency, and like a marshmallow consistency. So what they're trying to look at, and they do this under fluoroscopy, and they look at aspiration into the trachea. And so they can see which consistency of food feeds that the patient does not aspirate. So that's what is advised to the patient. SG dilatation, manometry are of no consequence in these patients. They cannot help you. Means if you do an UES manometry, you will see that the pharyngeal contraction is absent, but this is a lack of pharyngeal contraction, or in coordination, you either place a nasogastric tube or you do a peg for them. If they can swallow without aspirating, we send them to the speech pathologist to handle their diet.
Any role of Botox?
Not really. Botox may be used in cricopharyngeal achalasia, where there's a non-relaxing cricopharyngeal muscle where Botox can be used.
So sometimes we get in a patient with dysphagia normal endoscopy, and actually it is something mediastinal compression or mediastinal mass. Yes. So can we differentiate it on manometry? Is there any criteria for that, or any particular?
No. So like I showed in the arteria lusoria, that you will just see if it is adequately compressing the esophagus, only then you will you may see a high pressure reading there. But many times what happens is we think a high pressure reading in the middle of the esophagus, we try to see, oh, is this a cardiac impulse? Or we try to say, is this an artifact in our own machine? Because sometimes if a dust particle gets, you may see an artifact. But there are no specific or diagnostic criteria of mediastinal compression. Okay.
That was very nice, sir. Thank you very much for the nice talk and elaborative one. I think we should conclude and go to the next talk. Next talk is by Dr. Shrikant Mukhewar, sir. It's regarding gas, bloating, belching, and aerophagia. So I request Dr. Mukhewar, sir, to present the talk.
I think this is thanks, chairpersons. This is a very interesting topic. Though we've been practicing for the last 40 years, I think much weightage has not been given to this topic. And I thought that I'll discuss this. Now, the concept is gas is so important, especially in Indian subcontinent. Everybody is focused and, obsessed, I should say, obsessed with the gas. But looking at the quantity, it is only 100 to 200 ml of volume which is there. I was just surprised to read that stomach has only 10 ml of gas and the small intestine has 10 ml of gas. It's predominantly the gas is there in the large intestine, and that is around 100 ml. The composition, it's mainly nitrogen, predominantly nitrogen. You have oxygen, CO2, hydrogen, and methane. Their composition varies depending upon the bacterial flora and what you eat and what is the substrate. The distribution of the gas occurs amongst the GI tract which I have discussed. Input of the gas, predominantly input occurs once you eat something, the gas goes in. That's a major input. Apart from that, the carbonated beverages, that causes input. I think that we'll see in the next. And the gas is liberated by organisms and metabolism. So these are 4 sources of the gas. And the output, the eructations, they bring out the gas. The flatus organisms consume gas. So there is a dynamic process which is under the tight control, which with the intake and output being controlled. It's very interesting to know that there are CT volumetric techniques which can measure the amount of the gas. And the second technique is a washout technique by which you can flush the gas, collect via rectum, push it through the balloon-filled tube in the jejunum, and pushing the argon gas, you can measure. Radio-labeled argon is used and you can measure and wash out. And the accuracy has been quite good in both these techniques. There occurs a diffusion of gas between the lumen and the blood. As you can see here, this is a stomach, and the predominant the gas is present in the large intestine. In the standing position, this is there in the supine position, while in the standing position, the entire gas, I think this is in supine position, the gas is above because it is lighter. So you see the gas above. And the fasting and the post-meal, the gas increases. But if you see stomach, small intestine, and colon, the gas in the colon increases, but not so much in stomach and the small intestine. Now, what is bloating? Bloating is subjective, while distension is objective. So bloating is gassiness, fullness, trapped gas, or feeling of pressure. Ladies feel that I feel that I'm like a pregnant woman. So objective is, many people, they say that postprandially my abdominal girth increases. So that is objective. 60% of the bloating patients will complain of distension. So basically both these terms can go hand in hand. What is the prevalence in general population? 16 to 31%, almost 3 out of 1 person, a normal person, would complain of bloating. 2 out of 3 persons in IBS would say that gas is there. It impairs quality of life in 50%, which is a significant number, and coincides with other GI disorders. Now, in all functional bowel disease, what you have is a Rome 4 criteria. So, functional bloating and distension should be the only predominant symptom without the other things like IBS, constipation, diarrhea, and postprandial distress syndrome. So you should not have all these things. It should be the only symptom, at least 1 day a week, predominant symptom, onset 6 months, and should be active for last 3 months. So that is defined, and in clinical practice, what you have is a mixed bag. People will have bowel symptoms and nobody will come predominantly with only bloating and distension. But I recently got a young girl who's come from the States who was only having predominant bloating and sensation without any altered bowels. And I was happy to see that she was better with rifaximin. What is a pathophysiology? A very complex pathophysiology. When you don't understand, it's always said to be multifactorial. Always can be organic and functional. So, though the percentage of organic diseases are less, functional is more. It is already presumed that the gas is more in these patients, but it has been seen by volumetry that only 25% have more gas. So, dietary factors, the pathophysiology are dietary factors, small intestinal factors, large intestinal factors, abnormal motility, and brain-gut axis. So I'll be discussing pathophysiology along this. It's a common misnomer that the gas is increased, but it's only increased in 1/4 of the patients. A SIBO, once you have the two important factors which are there in bloating and distension is SIBO and carbohydrate intolerance. One has to give importance to this, and it is said that bacterial fermentation of carbohydrate leads to more gas. The prevalence in the food intolerance has been seen to the large extent in many with lactose, fructose, especially disaccharides or unabsorbed sugars. There was one study which has shown that patients with IBS, those who did not have bloating, had a less number of ruminococcus and eubacteria. So probably these are the two organisms which are responsible for bloating of the patient, or the abnormal motility is there, gastroparesis, scleroderma, intestinal pseudo-obstruction. It's been seen that patients who are IBS constipation with slow transit will have more gas as compared to those with normal transit. Probably gives more time for bacterial fermentation. Pelvic floor dysfunction delay the transit and is responsible for gas. This is the abdominophrenic dyssynergia. That is also supposed to be one of the factors for perceiving distension or the bloating of the abdomen. What happens normally when the gas goes into the intestine, the reaction in a normal person is that the diaphragm goes up and the abdominal muscle contracts. So that is how the longitudinal capacity of the stomach increases by movement of the diaphragm up and the contraction of the muscles. In patients who have abnormal viscerosomatic reflux, the diaphragm contracts and comes down, and the abdominal wall relaxes. So a reverse happen, and this is abdominophrenic dyssynergia, which is also one of the important factors for perceiving distension. Visceral hypersensitivity. There are experiments where the balloon distension have shown increased sensitivity, and there is a complex gut-brain interaction. Initially, it was seen as brain-gut interaction, but now the term is changed to gut-brain because gut has importance over brain. And it is increased by anxiety, depression, somatization. Apart from organic causes, as I said, two important things which you should remember. You have a small intestinal bacterial overgrowth and carbohydrate intolerance are the important factors. But apart from that, celiac disease, pancreatic disease, malignancies, obstructions, hypothyroidism, all are associated. But in clinical practice, what you have more important is functional dyspepsia and functional bloating, which accounts for the majority of them. History. Now, once you have this, you have to find out whether this is a food related, what are the bowel habits, history of surgery, medicines, most important alarm symptoms, physical examination and rectal examination. Breath test. I think we've been using breath test much less. I think these are the group of patients where the breath test should be used mainly to confirm about carbohydrate malabsorption. You may have to do celiac serology, endoscopy if they have alarm symptoms, and anorectal functions if they have altered bowels. So the diet is, they should be asked to take low FODMAP diet. In gastroenterology, irritable bowel, low FODMAP. Functional dyspepsia, low FODMAP. Bloating, low FODMAP. So all, low FODMAP and gluten-free diet are the important, and the improvement occurs in 80%. So the first step is change their diet. Second, you may use probiotic and antibiotic. These are the groups: Bifidobacter, L. sporogens, Bacillus have been found to be useful. There are trials of rifaximin given cyclically for a period of years with global symptom improvement, 41% versus 22% with placebo, reduction of bloating scores, and hydrogen breath test. So what you should not eat? The important things which you should not eat are all good things, Mango, the watermelon. I always try to remember it like that. The mango, watermelon, apple, pear. So these are the fruits which you should not eat. You should not be eating milk, ice cream, honey, sugar. All these are very tempting things. And then you should not be eating the cabbage, fulgobi, broccoli, onion and lasun, and kaju and kismis. So this is all the high FODMAP diet you should not be eating. And what you should eat is all this. Rest you can always eat. Treatment. Antispasmodics have been treated with global improvement, 46%, 38%. Lubiprostol, linaclotide, prucalopride, and tegaserod are mainly for patients who have constipation. Neuromodulators, amitriptyline, escitalopram, where you feel that there is a phrenic viscerosensory dyssynergia or increased visceral sensitivity. There is an improvement with peppermint oil and some Japanese medication and hypnotherapy. So I will come to the approach of these patients. When you have patients with chronic bloating and distension, first thing which you should find, whether there are alarm symptoms. What are alarm symptoms? Whether the patient has anemia, weight loss, GI bleed. If yes, get the endoscopy, labs and imaging and find out the organic disease. If no, are there symptoms predominant to altered bowels? Yes. Then if constipation, get their manometry and transit study. If diarrhea, check celiac serology or SIBO breath test. If no, are the symptoms diet related? If the symptoms are diet related, institute low FODMAP diet, improvement continue? No. Then treat for some abnormal viscerosomatic reflux, improvement yes. Continue therapy. If no, consider breath test. So basically, in a patient with bloating, find out alarm symptoms. If alarm symptoms, investigate. Find out bowel related. If bowel related, get manometry. Find out food related. Try them low FODMAP diet. And if that does not get better, then you can have antibiotics and visceral analgesics to use. Now, another symptom which is common in practice is belching. What is belching? It's an oral expulsion of the air from the upper GI tract. It can be audible or silent. What is a physiological? 30 times in a day is a gastric belching, and the 13 times per day is supragastric belching. Epidemiology, 3.4% referral, 50% of the dyspeptic symptoms will have belching. The diagnostic criteria according to Rome 4, it should be bothersome, more than 3 times a week, onset 6 months before, active 3 months before, for a period of 3 months. Now, belching, you have predominantly 2 types of belching, gastric and supragastric belching. In the gastric belching, the escape of the air occurs from the stomach to esophagus during the transient relaxation of the ileus. And in supragastric belching, it's a behavior disorder. What you get is the contraction of diaphragm that causes a negative pressure wherein the air is sucked from the atmosphere into the esophagus. Sometimes it doesn't go into the stomach and is expelled out. This, and in another, there is a contraction of tongue and pharynx. The pharynx pressure increases over esophagus, which leads to ingestion of the air in the esophagus. I'll give you these simple diagrams. What happens in supragastric belching? Because of diaphragmatic contraction, there occurs a negative pressure in the esophagus, which leads to transfer of air from the atmosphere to esophagus, as you can see here, and the ileus is closed, and that causes a reversal of the air in the opposite direction. So this hardly any quantity of air goes into the stomach. In the supragastric belching, the comes in the esophagus and goes out. While in gastric belching, what you have is an intragastric stomach. When there is a transient relaxation, the stomach, the air goes out, the ileus is closed, and pressure increases, and the air distends the esophagus, which leads to relaxation of the upper esophageal pressure. So supragastric is voluntary, while gastric is involuntary, reflux mediated. This is not physiological, this is physiological, requires medical attention, rarely requires attention, does not occur during sleep. If you talk to the patient, you have patients coming in OPD, continuous belching, immediately diagnose that this is a supragastric belching, anxiety disorder. If you talk to the patient, his belching will stop. Does not occur during sleep. It's a high frequency. Within a minute, patient will belch on 10-15 times. This is less frequency. Why? What is difference between supragastric belching and aerophagia? There is a air suction, air stays in stomach for a while, but goes out. Main symptom is belching, wherein air is swallowed, transported distally by peristalsis into the intestine colon, leading to bloating, distension, and flatulence. So aerophagia, the main symptom is bloating, distension, and flatulence. Associations, 50% of the patients will have belches, 50%, and they have supragastric belches. The reason is not known, but they respond to PPI. For patients with functional disorders, dyspepsia, rumination, OCD, bulimia, anxiety have also belches. Excessive repetitive belching is supragastric. Impedance is gold standard. And now you see here the graph of impedance moves from here to this direction. So this is gastric, while in supragastric, it is moving like this. So it is a supragastric belching. So sometimes to differentiate between the two, one has to use impedance. And this is a manometry. I'll not go into the details. The aerophagia, the movement of the gas. Now, what is the treatment? If it is a supragastric belching, the treatment is behavior disorders, required psychoeducation. The patient try to rule out organic disease because the patient wants that their organic disease to be ruled out. Speech therapy has been associated with significant relief. You have to sit with the patient, tell him what is the mechanism. So there are basically, it's a sort of reassurance, psychotherapy, explaining the patient mechanism. But the speech therapy and cognitive therapy are the ones which are important. There is hardly any role of drug therapy in these disorders. Thank you.
Thank you, sir, for covering this important topic in our clinical practice. Very nice lecture. Any questions?
Sir, in supragastric belching, why there is some, a pressure point which initiate belch? Husband दबाता है, एक हाथ दबाया तो डकार निकल रही है. This is common symptom, but it is seen universally. Everybody is saying same thing. While these patients never come in contact with each other. So, is there any mechanism?
Possibly
Especially by
hypersensitivity. Hypersensitivity related. So basically, you know, when it starts, supragastric belching start as a phenomena when you have contractions of diaphragm, negative pressure, the air being sucked in. And then, you know, that becomes a habit in the due course of time, and the patient tries to do it probably to attract the attention. That is what is said about supragastric belching.
What I found mainly these patients, they have continuous habits and they come in OPD and sit like this. So when after putting a rice tube, they respond. And that vanishes most of the time.
I basically don't know
one
about
day
the rice tube treatment, but I think if you drive the attention, divert their attention, or if the patient during sleep or talking to the patient, all these supragastric belches, they disappear.
Because probably that rice tube is causing irritation and that is diverting their mind.
Yeah,
So
maybe it's a
that
counter irritation, phenomena,
yeah.
something, maybe it's working, but in the literature, I couldn't find anything of this sort. Evidence based. Yes, Uday.
Symptom of gas is the complaint of gas climbing into the head.
Sir, it is migraine. Migraine it is mostly.
No, I don't think that there is a physiological base for it. Yeah, Amit.
Sir, very nice talk and a very important topic.
On Kurun.
Yes.
Yeah.
Sir, you talked about the abdominophrenic dyssynergia. I think all dyspepsia, bloating, also in belching, it is a very important pathophysiology.
Yeah.
And now I think from management perspective, diaphragmatic breathing, that is pranayam, is coming up as a therapeutic modality. And it
In
is
fact, I
targeted-
had last slide, which I haven't shown because
Yeah, yeah.
I mean,
Even gastroenterology, RCT has come for GERD, diaphragmatic breathing has shown to be an effective therapy.
yeah, yeah.
Down therapy. So probably all of these can be addressed by going for diaphragmatic breathing. So
Yeah, in fact, I had that slide of diaphragmatic breathing, but I could not get the solid references showing the importance of diaphragmatic breathing. Maybe it's theoretical, but are there any controlled trials for GERD?
So is that Anulom Vilom?
yes.
Sir, have you seen increase in the incidence of reflux following Patanjali Yoga's Kapalbhati system? Repeated breathing.
See, basically,
Has it increased? Actually, lot many patients have come
yeah.
who were doing this and then they started getting reflux symptoms.
See, basically, if you do, reflux is such a common thing, you know. So unless until you do quite a scientific study to find out whether, and there are different type of yogas people do. So anything, I think, which increases the intra-abdominal pressure, probably the patient should be more prone for GERD-like symptoms, you know. Anything you take in the air and take out, exhale out. So if such things are there, anything that is going to increase the intra-abdominal pressure, leading to more reflux.
But probably eventually your diaphragm may become strong and the LES may become tighter.
We came
See-
across one patient of SMA obstruction.
I know. I know the patient.
And who was doing Kapalbhati for 600 times also.
Thank you, sir. It's
Thank
time
you.
to move on.
Thank you.
Next topic is diagnosis of GERD, pH, and impedance. And I request Akshay Kulkarni to introduce our speaker, Dr. Anshuman Elans.
Good evening, everyone. It gives me great pleasure to introduce Dr. Anshuman Elhens. He is, I think I can proudly say that he's my close personal friend and a very important colleague who has worked with me for at least 1 year when I was doing my fellowship in SGPGI. He joined as a consultant in SGPGI after doing his DM from All India Institute of Medical Sciences. And he's done his undergrad and post-graduation from KGMC Lucknow. He is interested in pancreas, being a disciple of Dr. Pramod Garg sir, and he has recently published at least 50 articles, most of them about pancreatology, and his special interests lie in advanced endoscopy and pancreatology. But he is an excellent academician and an excellent teacher, and I'm sure he'll deliver a very entertaining as well as enlightening lecture today. Floor is all yours, Dr. Anshuman sir.
Thank you, Dr. Akshay, for the kind introduction. I would request if the technical team can share my video from their end. Very good evening to all of you. This is Dr. Elhens from SGPGI Lucknow. And at the outset, I would like to thank Dr. Mukkewar for the kind invitation. And I would have been given the arduous task of discussing the diagnosis of GERD using pH and impedance monitoring. And I would set the ball rolling with the problem statement that GERD is not an uncommon disease. In fact, the notion that it is a disease associated with Western lifestyle is not true. In fact, a study from AIMS, New Delhi, by Professor Vinita Ahuja's group shows that almost 15% of the urban population has GERD, and a similar study from SGPGI Lucknow by Professor Ghoshal done in the villages of Jaunpur shows that GERD is equally common among the rural population. So how do you go about diagnosing GERD? If you're thinking you need any fancy equipment to diagnose GERD, you're mistaken. In fact, the time-tested symptomatic approach if the patient has typical symptoms of heartburn and regurgitation, and you're diagnosing them as GERD is pretty pragmatic, and you'll be correct around 2/3 of the time. On the other hand, you can be using the trial of PPI as a method to diagnose with a good sensitivity, but the specificity is limited because a number of other disorders mimicking GERD might respond to PPIs as well. So what do you do in those who don't have these typical symptoms, or those who don't respond to PPIs or don't tolerate PPIs? They are the subset in whom you need to evaluate further. So what do you do with the further evaluation with? You do an upper GI endoscopy. And if you see any of the given findings, then you are reasonably sure that you are not dealing with anything but GERD. So if you're seeing LAC or D esophagitis, you're seeing a peptic stricture or a long segment Barrett's esophagus, these endoscopic findings are pretty specific for GERD. And if you see them, you can be reasonably sure that you're dealing with GERD. But the problem is that they are present in only a minority of patients with GERD. And in fact, for the majority others, you will need to resort to pH metry, but not just pH metry, but multi-channel intraluminal impedance and pH metry. So in short, the indications for doing the MII pH metry is those with atypical symptoms, those who are PPI refractory or PPI intolerant, or in those in whom you need to diagnose GERD objectively, and you're planning to do an endoscopic or a surgical anti-reflux procedure. Needless to say, these need to have endoscopy findings which are not very typical of GERD. So the debate whether to do testing on PPI or off PPI has been going on since long, but the Lyon consensus and the Porto consensus has made it very clear of recent that whether to do testing on PPI or off PPI depends on the intent of testing. So if the intent of testing is to objectively diagnose GERD, then definitely you need to do it off PPI. But if you're reasonably sure that the diagnosis is GERD and the intent of testing is whether the patient is responding to the therapy or not, then only you need to do on PPI. That is only if you're having findings of LAC or D esophagitis, Barrett's mucosa peptic stricture, or a prior positive pH testing, then only go for on PPI testing. Otherwise, for all indications, go for an off PPI testing. You need to stop PPIs at least 7 days before start of the test. So once you are clear of the indication and you have checked whether you need to do on or off PPI testing, you need to ask the patient to be nil by mouth for at least 4 to 6 hours prior to the procedure. The patient can carry out the regular activities, meals, and they need to keep an activity diary where they need to document their starting and stopping of meals and whenever they change their position from recumbent position to erect position. So let's have a look at the tools of the trade. So here is the impedance and pH catheter which is used in our laboratory, and you can see that it houses a number of pair of metal electrodes. These are the impedance electrodes. So there are 6 pairs of electrodes located at 3, 5, 7, and 9 centimeters from the lower esophageal sphincter. And then there is another pair of electrodes at 15 and 17. So these are the impedance electrodes. And then there are 2 pairs of pH sensors, one at the tip, which is located at least 10 centimeters down from the lower esophageal sphincter, and another one located 5 centimeters above the lower esophageal sphincter. And this catheter is connected to a data logger, which is worn by the patient. And the data logger has a number of buttons in which the patient can mark whenever he changes his position, starts or stops a meal, or he has symptoms suggestive of heartburn, chest pain, or regurgitation. Obviously, before putting the catheter through the nose of the patient, you need to calibrate the pH sensors using solutions with a given pH. Once calibrated, the pH catheter can be positioned inside the esophagus of the patient transnasally and then fixed with the tape at the nair of the patient. So how do you adequately position the catheter? Ideally, it should be done by performing a manometry first. You locate the LES and then you put the esophageal pH sensor at least 5 centimeters above the LES. The other way could be a station pull-through method, which is used many times by experts. They put the catheter down so that both the pH sensors are in the stomach and recording low pH, and then they pull slowly until one of the sensors gets into the esophagus and the pH changes, and then they pull around 5 centimeters more. So this is a rough estimate, but it should be done only under expert guidance. So before we come to the interpretation of the pH testing, let's talk about how the impedance work. So basically, the impedance catheter has a pair of electrodes across which alternating current is flown, and the resistance encountered to the alternating current is called impedance. So obviously, if there is a bolus surrounding the pair of electrodes, then the flow of current will be much more easier because of the presence of ion, and the resistance or the impedance will fall, and hence the impedance will be low. So if you have any refluxate food or saliva coating both the pair of electrodes, then the impedance will fall. On the contrary, if you have air, the impedance will be higher. So why not just do a pH metry, and why to resort to impedance metry as well as pH metry? So for that, you need to understand why historically the 24-hour pH metry was chosen and what are its cutoffs. So the traditional 24-hour pH metry measures only an acidic reflux when the pH is less than 4. So this arbitrary cutoff of 4 was chosen because it was thought that pepsin acts best at a pH less than 4. But now we know that this is not true. GERD is not due to pepsin, and it is acid itself which is damaging the esophageal mucosa. And also, even pH, which is acidic in the range of 4 to 7, can damage the esophagus. So you need to measure those weakly acidic refluxes too, and alkaline refluxes too. So this chemical property of reflux, whether it is weakly acidic or alkaline, which is not detected by the traditional 24-hour pH metry, can be detected by impedance metry. You can also get to know about the physical property of the reflux, whether it's just liquid or liquid plus gas. You can know about the direction of travel, whether it is traveling antigrade or if it is traveling retrograde. And also you can know about the height of the travel of the reflux. So all these parameters make the impedance pH the gold standard to diagnose GERD. Now let's look at the terminology which is used. So reflux is defined as any return of liquid or liquid with gas into the esophagus from the stomach. A liquid reflux is defined whenever there is a fall in impedance by 50% in the 2 distal electrodes. A gaseous reflux leads to an increase in impedance by at least 3000 ohms in 2 consecutive sites. Acidic reflux is that with a pH of less than 4. A weakly acidic reflux is that with a pH of 4 to 7, and an alkaline reflux is that with a pH of more than 7. We'll talk about the re-reflux once we interpret the signals. So now let's have a look at this graph. If you have a look at the first graph, the first 6 sensors labeled Z are the impedance recordings, and the last recording, which is the pH recording, is the esophageal pH recording. Then let's have a look at the impedance recording of this patient. So here you can see the impedance falling as we go retrograde. The impedance is falling in a retrograde direction. So definitely this is a reflux event, which is liquid since the impedance is falling. And when you have a look at the pH falls, but it doesn't go below this dotted line of pH of 4. So this is a weakly acidic reflux, liquid reflux. Now let's have a look at the second recording. So here you can see the impedance showing a fall, which is there traveling in a retrograde direction. And since there is a fall in impedance, it is a liquid reflux. And you look at the pH, it is a liquid acidic reflux. Then let's have a look at the another recording. Here you see the consecutive fall in impedance in the consecutive electrodes traveling in a retrograde direction. So this is definitely a liquid reflux, but then you look at the pH doesn't fall, rather it's more than 7. So this is an alkaline liquid reflux. Now let's have a look at this last tracing, which is pretty interesting. Here you can see that there is a reflux, liquid reflux, as documented by a retrograde fall in impedance, and this is an acidic reflux. But as you see that the esophagus is acidified, it does not return to normal, but the liquid volume is cleared very quickly so that the impedance returns back to the baseline. And then there is another reflux event, but by this time the pH has not been cleared. The pH is still acidic due to the first reflux episode. So this is called a re-reflux. So if you are just using a traditional pH meter, you will miss this additional episode of reflux, which you can measure by only using impedance manometry. So this is a re-reflux. So once you have recorded for 24 hours, but at least for 16 hours, the proprietary software gives a series of metrics. The most commonly reported of all is the acid exposure time, which is the percent time pH is less than 4. And commonly, if this is more than 4.5%, in most of the software, it is the automated analysis reports it as significant acidic reflux. But there are a number of other parameters which can be used to calculate the D-Meester score, and GERD can be diagnosed conclusively if the D-Meester score is more than 14.7. But now it has been shown in a number of other studies that this acid exposure time, the upper limit of normal, is close to 6%, and this has been endorsed by the Porto and the Leon consensus of late. There are a few newer metrics which you need to be aware is the PSPW index, or the post-reflux swallow-induced peristaltic wave index. So every reflux episode should ideally be followed by a swallow within 30 seconds, which is a reflex to clear the esophagus of the acid which has refluxed. So ideally, this should occur more than 60% of the time. If it isn't occurring 60% of the time, then it's abnormal, and you can use this as an evidence for GERD. If your other parameters are not very supportive of GERD, there is another index which can be calculated with MII pH impedance metry, is the mean nocturnal baseline impedance. Here, you measure the baseline nocturnal impedance during the night at 3 10-minute intervals, and you take out the mean nocturnal baseline impedance. So whenever the esophageal mucosa is injured, it becomes leaky, and this leakiness leads to increased flow of current, and hence the impedance falls. So an injured esophageal mucosa, suggestive of erosive esophagitis, is suggestive of low impedance. So if you have a low baseline impedance, you can use it as an additional parameter in favor of GERD. There is still much more parameters which can be reported by pH, the MII pH metry, is the reflux symptom association. This is done by measuring the symptom index and the symptom association probability. So if the acid exposure is not increased, but there is still a positive reflux symptom association, the patient can be diagnosed confidently with reflux hypersensitivity. On the other hand, if there is a normal acid exposure and there is no reflux symptom association, then the patient can be diagnosed confidently with functional heartburn. So things are not all rosy with the MII pH impedance metry. There are certain limitations. You can see in these two pH metry graphs of erosive esophagitis and stasis esophagitis, both conditions are associated with an injury to the esophageal mucosa, and hence a leaky mucosa, and hence a fall in impedance. And if you look at the impedance tracing, these are touching the baseline. Even if there is a liquid reflux, it would not be able to catch it, because the impedance at baseline is so low because of the widespread erosion. Apart from this, the other limitations are that the proprietary software or the automated analysis often overestimates the number of episodes. When using just impedance, you need to count it manually. This impedance technique is not available with the wireless technique. And most of the impedance metrics, apart from MNBI and PSPW, show a very poor correlation to therapeutic response. So in summary, so apart from the traditional catheter-based pH monitoring and the pH impedance monitoring, we now have the wireless pH monitoring capsule, which can be placed in the esophagus around 6 centimeter above the squamocolumnar junction, where it can be applied with a clip. And since the patient does not have to bear with the catheter coming out of his or her nose, it is very much tolerable to the patient. And therefore, it can be kept for longer duration, and the longer it can be kept, higher is the diagnostic yield. But then there are downsides, that it requires an endoscopy to place the capsule, and on the other side, the technology of impedance is not associated with this wireless capsule. So still, I would recommend pH impedance monitoring as the gold standard for diagnosing gastroesophageal reflux disease. And in summary, basically, if you have don't have a conclusive evidence of GERD in form of LAC or D esophagitis or acid exposure time of more than 6%, then you need to resort to adjunctive supportive measures using impedance metrics such as the MNBI, total number of reflux, reflux symptom association, and PSPW. So thank you so much.
Thank you, Dr. Anshuman. Very nice coverage of topic which we are not very used to. Any questions?
Anshuman, a great talk.
Thank you, sir.
Just wanted to ask you, what
Sir.
is the benefit of 24 hours versus 48 hours pH metry? I mean, the reflux episodes gathered in 24 hours versus that of 48 hours. What is the advantage?
Sir, the longer we measure, the higher is the diagnostic yield. But the outcome metric for even the 48-hour measurement is the percent of time which pH is below 4. So the outcome metric will be the same, but the longer we measure, the higher will be the yield, and more likely we'll be able to catch the GERD, because there is a lot of day-to-day variability. So in a single day, we might miss GERD, but if we prolong the duration, we are more likely to catch the GERD.
Dr. Anshuman,
Sir.
is belching same as gas reflux? And can it be picked up?
Sir, belching,
impedance and pH?
so if we go by the strict definition of reflux, isolated gas reflux is not labeled as a reflux. For the definition of reflux, we need either a liquid or a liquid plus gas. So just a gas reflux is not, by strict pedantic definition, it cannot be counted as a reflux. But if you go by a physiological means, yes, you're quite correct that belching is a type of reflux of gas, but particularly if you're talking about gastric belching.
I just would like to have one comment for the audience here, that if you want to know whether the patient has reflux, then the testing has to be done off PPI. Because if the patient, you want to know that whether the patient has reflux. And if you want to know that the patient has already have reflux, but want to know whether the patient is responding or acid, whatever PPI we are doing sufficient or not, then probably I think that should be on the treatment. But in clinical practice, what is your view that most of the things when you want to know, because functional heartburn and others, so majority of the times it is better to do off PPI than on PPI.
Very true, sir. Very correctly said that all depends on the intent. We are our intent to do the pH metry. So if our intent is to diagnose GERD, it should always be done off PPI. But if our intent is to see whether our therapy is working or not, it should be done on PPI.
Hello, Dr. Anshuman. Great talk.
Thank you, sir.
Good evening. My question is, when we are doing impedance to look at non-acidic reflux, so what is the therapeutic implication of non-acidic reflux? Do we have any therapies?
Sir, so basically everything lies in the nomenclature here. So traditionally, when the nomenclature was acidic reflux was said, that it was said to be acidic reflux was labeled as anything with the pH less than 4. But even the so-said non-acidic reflux are acidic actually, because they have a pH between 4 to 7. So PPIs work in that case also.
Above 7 refluxes which are above 7 alkaline refluxes.
It has been shown that PPIs do decrease the amount of reflux because they secrete the total amount of gastric secretion, although they don't have any effect on the G junction, but they do decrease the number of reflux episodes.
Okay, thank you.
Anshuman, if you have a patient with refractory GERD, it's a more of non-acid reflux than the acid reflux majority of the times.
Sir.
Yeah, I mean, those type of things.
One last question by Dr. Prashant.
So does this help to quantify or pick up volume reflux, so to say, regurgitation, 24 hours pH?
So if we are using the impedance technology, it does help to quantify the volume reflux in terms of the number of reflux episode, because the acid clearance takes a longer time. In fact, volume clearance, as we had shown, that it is quite fast. Volume reflux is better measured with impedance technology rather than the pH only.
So it can
because
help us
episodes can be counted.
Help us to choose patients for surgery.
So not really, because with regards to choosing a particular therapy, there are certain metrics which help us know whether the patient will respond to PPI, or in that sense endoscopic anti-reflux procedure or surgical therapies. And the best marker which correlates with therapeutic response is acid exposure time. Apart from this, there are certain newer impedance markers such as MNBI and the PSPW index, which I talked about. So these have a very good correlation with therapeutic response. Apart from these, impedance has a very poor correlation with therapeutic response. So not very good for choosing type of therapy, apart from acid exposure time and MNBI.
We are happy to announce that we have impedance for the last 1 year.
Congratulations. Dr. Anshuman, I request you to take up the online questions, answer them separately. We don't have time to discuss them right now.
Sure, sir.
So thanks for your talk here. Now we move to the next lecture in this meeting, and it's on transit studies of stomach, small bowel, and colon. And Dr. Nikhil Khobrakade, please.
So very good evening, sir. Myself, Dr. Nikhil Khobragade, and today I'm presenting this transit study of stomach, small bowel, and colon. So basically, this is all basics of what is the stomach, what is the motility pattern of a stomach. So generally, stomach, we divide the stomach into two parts: oral, the upper part, and lower part. The upper part, that is fundus, it generally helps in accommodation of the food particle, and it acts as a gastric reservoir. And then there is a slow antral contraction which moves down the food particle into the antrum. And the lower part is generally make up of the lower body and antrum. It's the mainly function of this is the trituration, that is they break down the solid particle into very small particle, and then there is a peristaltic contraction, and this push the food into the small intestine. That is doing. So there is a basic electrical activity of stomach, and it is the pacemaker. You can see that the pacemaker is located at along the greater curvature in the upper one third and lower 2/3, and this produces the slow waves which are produced by the interstitial cells of Castle. It's responsible for a rhythmic contraction. It is not a true action potential. It is not a true action, a true contraction, and its frequencies varies from 3 to 12 per minute. When this slow wave is coincided with an action potential, we call it the spike potential, and spike potential is a basic contraction of the stomach. So then there's a migrating motor complexes. There are 3 phases, that is phase 1, phase 2, phase 3. Phase 1 is simple basic electrical activity. Phase 2 is irregular spikes with contraction, and phase 3 is mainly for contraction. So there are various factors that influence the rate of emptying, that is phase of ingestion time, volume, osmolarity, pH, caloric content, and viscosity. So why do we need a GI study? Because all we know that there are a variety of the symptoms, and in 50% of the patient, there is no cause is found, and we require the workup to identify the causes. And also that helps in to identify the patient who will benefit from prokinetic drugs or just other treatment to elevate the symptoms. So coming to the GI transit study, generally the gastric emptying time we calculated by scintigraphy, calcium capsule technology, breath test, and gastric relaxation studies we are done with the barostat, SPECT, scintigraphy, then pyloric sphincter test, and anteroduodenal motility. So what is meant by scintigraphic study? It is a gold standard. Here what we have to do, we have to do the inject a meal which is radio labeled, and the counts are measured by the gamma camera, which are directly proportional to the volume of the meal in stomach. The solid meal is composed of a 120 gram of an egg, which is mixed with a 99 technetium, 2 slices of white breads, and 30 grams of strawberry jam, and 120 ml of water. The total energy of the meal is 255 kilocalorie. And the procedure is, that is, we ask the patient to consume the meal within 10 minutes, and then we have to take the images at 0, 60, 120, 180, 240 minutes after the meal ingestion. And we have to, the counts are increases when the solid is moved from posterior part of fundus to the more anterior located antrum. And there is a we have to do the correction, we call it a depth related correction, and that this is corrected by this formula is there by anterior counts into posterior counts upon 1/2. So what precaution we have to taken to do this scintigraphic study? We ask the patient to fast overnight, to stop any medication that affect the G motility for at least 5 days. Smoking, we have to ask to prohibit it. Glucose level should be less than 275 because hyperglycemia reduces the gastric emptying time. Then if you are doing the colonic study, then we have to ask patient to order laxative. And for colonic study, we have to ask patient to consume normal diet for 2 days before the test and 4 days after the test. So what is the interpretation? If the retention is more than 60% at 2 hours, or it is more than 10% at 4 hours, which is called as a delayed gastric emptying. And if it is a retention of less than 70% at 30 minutes or less than 30% at 1 hour, is called a rapid gastric emptying. Then another, there is a, what we did is a solid phase. Now it is a liquid phase gastric emptying. This liquid phase gastric emptying is different from solid phase because there is a no trituration, there is a no lag phase, and it is empty more rapidly than solid. And here the isotopes is used is a 11 111 indium diethylene triamine pentacetic acid. So if you see the photograph, you can see the first one. This is a solid phase and this is a liquid phase. You can see that the food is more distributed at antrum rhizome, where in liquid phase this is diffusely distributed throughout the stomach. And if we draw the graph, the solid phase graph is like a sigmoid graph because there is an early lag phase, while in a liquid phase this is mono exponentially expanding, and after 240 minutes you can see that this all the food is distributed in the terminal ileum. So what are the limitations? So there is a no consensus guideline available. There is an optimization of the image time. There is a need for normative data on substitute meal, the role of glycemic control in diabetic patient, value of monitoring symptoms during a study. There is a no scale to assess the severity of a delayed gastric emptying, and if the patient is undergo the post-surgical, so there is a no data, reference data for a post-surgical gastric patient. And second is wireless capsule technology. This capsule that measure intraluminal pH, contraction and pressure. The capsule is swallowed with a standard test meal. In healthy subject, it emptied from the stomach into duodenum approximately 5 hours after ingestion of a meal. and it's correlated with 90% of the emptying with a technetium labeled solid meal. It has a very good sensitivity and specificity in detecting the gastroparesis. Then we have to do the breath test also. The basic principle is like that. It is all the non-invasive method. Here what we have to do, we have to meals are labeled with a 13 carbons, that is included 13 carbon octanic acid. It is emptied from stomach into the duodenum where it is absorbed. Then this label nutrition are metabolized in the liver to 13 carbon dioxide, which is extracted in the lungs, and the level of this carbon dioxide detected in the breath sample. So breath sample is collected at 45, 90, 120, 150, and 180 minutes after the meal. It's generally comparable with the scintigraphic studies. Only the pitfalls include if there is a malabsorption condition, liver disease or lung disease, the results are spurious. Then fundal accommodation and intragastric distribution studies also we have to do, because the many symptoms are responsible because of the disturbed fundal accommodation. For example, the early satiety that is more responsible with a disturbed fundal accommodation. So the tests are available are gastric barostat, water load test, and SPECTS. So what is gastric barostat test? So it measures the volume to which a gastric balloon can inflate at a given pressure, and patient with a visceral hypersensitivity experience the symptoms at lower level of distension. It is an invasive test, so it is generally not useful. SPECTS is another test. The basic principle of SPECTS is that the gastric mucosa accumulate the 99 technetium per technet after intravenous administration, and then we have to do the 3-dimensional SPECTS imaging study. It is a non-invasive method to measure a gastric volume, and it provides the accurate measurement of accommodation response in healthy and post-fundoplication patient. It's possibly also simultaneously assess the relation of a liquid or solid meal emptying and gastric accommodation. So this is a SPECTS array. You can see that if there is a disturb in 0 minute, the food is distributed more like in a antral part with a no fundus activity. So there is a disturbed fundal accommodation, and finally it is distributed in the ileum. Then these are another test, non-nutrient liquid and nutrient drink milk test. Here in this case, we have to ask the subject to drink 150 ml of liquid every 5 minutes until the maximum tolerated satiety is achieved. The endpoint is they require almost 30 minutes and result in a consumption of around 800 to 1000 ml of the nutrient milk. The subject with a functional dyspepsia or gastroparesis ingest much smaller volume of the water and report fullness, indicating the impaired relaxation and accommodation of the stomach. Then we come to the small bowel transit. In small bowel, there is no specific peristaltic pattern. There is a continuous antegrade and retrograde movements of intestinal chyme occurs in jejunum and ileum. And migrating motor complex, it is a more periodic contraction which act as a housekeeping role, and it moves the food particle from duodenum into the ileum. And terminal ileum, which function as a reservoir of the chyme before it passes into the colon. So the studies are available to do the small bowel and colonic transit studies are scintigraphic, hydrogen breath test, radio opaque marker, and wireless motility capsule. So basically the protocols for acquisition of processing the scintigraphic studies here. So here what we have to do, we ask the patient to take the milk, that is radio label milk, and we have to take images from 0, 30 minutes, 60, 120, 180, and 240 minutes. Up to 4 hours, it is a gastric emptying time. Then we have to take images at 5th hour and 6 hours, which is generally a small intestinal transit. And then for 24 hours, 48 hours, and 72 hours for colonic transit studies. So what these are a protocol basically. So there are 3 options basically. In option A, we have to do the whole gut transit study. Here what we have to do, we have to ask the patient to take a combined solid and liquid gastric emptying meal to assess the gastric emptying, small bowel, and colonic transit. So these are a procedure of acquisition of images. The images are obtained by 128 into 128 pixel matrix, and these are energy setting. and we have to take images at 60 second for 60 second in 0, 1, 2, 3, and 4 hour for gastric emptying time, and then 5th and 6th hour for small bowel, and 24, 48 hours for colonic transit time. Then there are option B, that the study is done only for small bowel transit study. Here we have to use liquid milk, and here also the same, but here we have to take images at 6 and 5 hours. So they already discussed that the meal we are using is only the technetium labeled egg sandwich with a liquid 2 slices of white bread, jam, and 120 ml of water. For combined solid and liquid milk, and for small bowel study, we have to take only the liquid diet. So measurement of the total amount of the activity accumulated in terminal ileum or transmitted into the cecum or ascending colon at 6 hours use as the index of a small bowel transit. If it is more than 40% of the total abdominal counts that is moved through small bowel into terminal ileum, the small bowel transit is normal. The delayed small bowel transit is typically seen as the residual activity in a multiple loops of small bowel without clear activity having progressed into terminal ileum or colon. A rapid small bowel transit is seen then where is the early cecal filling that is more than 10% of the activity in a cecum in a less than 70 minutes. Using the liquid phase of mixed solid, the small bowel transit time is normal healthy individual is around from 70 to 392 minutes. Then we come to the colonic transit study. Here we have to quantify the colon transit is based on a serial measurement of a geometric center. So here what we have to do, we have to give the numbers. That is for ascending colon, we have to give number 1, then hepatic flexure number 2, transverse colon 3, splenic flexure 4, 5th is a descending colon, 6 is sigmoid colon, and 7 is a stool. And here the geometric center is calculated by a count in each region multiplied by the region number and divided by the total count. So you can see here this 0.4 is a counts and 1 is a number that is in the ascending colon. And if you see, what we have to do, we have to multiply this count with a number, and then whatever the value is coming, we have to divide it by the total sum of these counts. So in that way, we have to count the geometric center. And based on that geometric center, we can calculate the 3 patterns of abnormal pattern, that is generalized slow transit, colonic inertia, and functional rectosegmoid obstruction. So generalized slow pattern is delayed progression of persistent diffuse retention of activity throughout all the segments, and geometric center is less than 4.1 at 48 hours and between 4.1 to 6.2 at 72 hours. While the colonic inertia is a failure of a radiotracer activity to progress beyond the splenic flexure, with a geometric center is less than 4.1 at 48 hours and 72 hours. While the functional outlet obstruction is a activity has progressed into the rectosegmoid colon, but then fails to be expelled, with a geometric center is more than 4.1 at 48 hours, but less than 6.2 at 72 hours. Then another study is the opaque X-ray marker. It is first described by the Hinton in 1969. It is a simple, inexpensive, reliable, and reproducible, but it requires a good compliance, produces the radiation exposure, and does not measure a transit of a physiological meal. There are 2 kinds of radiopaque marker available, Cis-mark and Colomark. Generally, we use a Cis-mark. There is each single capsule contain 24 to 20 radiopaque marker. So there are 2 methods. There is a single capsule technique or multiple capsule technique. In single capsule technique, the plastic beads or rings are being contained in one capsule. In one capsule contain 20 to 50 rings. And there are 2 methods, that is serial abdominal X-ray are taken after ingestion of a capsule until all the rings become clear from bowel, or only single abdominal X-ray on a day 5th, which is preferred because of the less radiation exposure. In multiple capsule technique, we have to ingest 1 capsule per day for 3 days, followed by the X-ray on day 4 and day 7, or only day 7. So here we have to divide the region into right, left, and rectosigmoid junction, and it is divided by the line drawn from a fifth lumbar vertebra into the pelvic outlet, and then left on side the iliac crest. So this is the right part, right colon, and rectosigmoid, and these are all the markers. So mean colon transit time was 20 to 30 hours in Asian population, and it is 30 to 40 hours in Western population. A delayed transit is defined as the more than 20% retention of a capsule in a single capsule technique with a single abdominal X-ray on a day 5. In multiple capsule technique, the colon transit time is calculated by multiplying the number of marker by 1.2. So coming to the next level, the wireless texting, it is a wireless smart pill. It is available and has been FDA approved. It is a portable small capsule that when swallowed, record and transmit the data to receiver as it travels to the gut. The capsule can measure the pH, pressure, and temperature to track the location of a gastric content and expulsion time from a different region of the bowel. The capsule is a one-time device that is activated and then swallowed by the patient who have a suspected symptom of gastric emptying delay. So this is a protocol. The patient undertakes an overnight fast, and then written informed consent has to be obtained. The patient given a standardized meal with water. Then patient ingests a wireless motility capsule with 50 ml of water. Patient gives a detail on the uses of event recorded and instructed to fast for further 6 hours. And then patient is then discharged and returning to the normal activity and return the recorder after 5 days. So these are a tracer, the recording obtained from the capsule. So based on that capsule, these are gastric emptying, small bowel transit, and large bowel transit. So when we swallow the capsule, there is a temperature rises in a body temperature. And how we calculate that the capsule is escaped from the stomach and enter duodenum, there is a sudden pH drop to stomach. So pH is dropped to stomach baseline. That abrupt rise in the pH is more than pH unit from a stomach base. That marks the exit. And the transit time is around 2 to 5 hours. If it is more than 5 hours, that there is a gastroparesis. In small bowel transit, the pH rise marks the entry. Abrupt pH drop of at least 1 pH unit observed at least 30 minutes after a gastric emptying marks the exit of the ileocolonic junction. And in if it is the transit time is 2 to 6 hours for small bowel, and if the pH drops marks entry into the cecum, the exit of the body is marked by a drop of temperature to room temperature, and here transit time is 10 to 15. So advantage is it is a wireless and penless, can be used in office setting without sedation or radiation, and provide information over the whole gut in addition to the area of interest of gastric emptying. Disadvantage, failure to capture a data, required repeat testing. There is a delay or total failure of the capsule to pass, requiring the serial X-ray to document the passage, or endoscopic or surgical removal sometimes. Inability to use the capsules for anyone with a possible stricture, altered anatomy, or severe pyloric stenosis. Thank you.
It was a difficult topic, but important one. Yeah.
Hello. What is the clinical importance of doing small bowel transit? Small intestinal
Sir, because so many symptoms, we do not know whether it is originating from upper GI tract or lower GI tract. And for small bowel, generally, if there is a colon diarrhea, or if it is a constipation, or there's a what is called irritable bowel syndrome, in that condition, we have to do the, or even in the case of malabsorption also. We did a small bowel transit study.
So Dr. Uday has to ask question.
So which of these are available in the city and in the country?
Sir, this is generally available in whenever there is a nuclear imaging center. That is, it is generally done by the nuclear medicine people. So I think in KM, when I was in Mumbai, in KM, that Dr. Shobna Bhatia used to do this study regularly for just for research purpose. For just for diagnosis, I don't think someone is doing.
No, but scintigraphies are available, na? Gastric and colon.
Gastric emptyings are available in Nagpur also.
But generally, gastroenterologists, they are very rarely doing this.
Yeah. Yeah, we're doing scintigraphy studies, as you said, and also the colon transit with the X-ray pellets.
X-ray, that is.
Both things can be done.
But radiolabel mail and everything that we are not generally doing. That's X-ray technique, that disease marker.
So nuclear medicine and X-ray is available. Those
Yeah.
things can be done without a problem. But I think other things, carbon dioxide,
Breath test and
etc.,
specs
I'm
and
not
everything.
sure.
Yes, thank you, Dr. Nikhil. Now we move on to the last topic. I think we have an eminent speaker, Dr. Amit Kavimandan from Amravati. He's going to enlighten us on choosing a right prokinetic. I think prokinetics are one of the most abused drugs by gastroenterologists. That's what I feel. So let's see what he has to say.
Okay, so good evening. It's
Most of the time.
actually very late. I'll be very brief. Thank you, Mukeva sir, for inviting me for giving this talk. So we are on an important topic, choosing the right prokinetic. As Dr. Abhijit said, it's a widely used and abused drug. So what is a prokinetic? The name itself says which promotes movement. It has been defined as a drug which enhances the coordinated GI motility and transit of contents in the GI tract, mainly by increasing either the frequency or the amplitude of GI muscular contractions, but without disrupting the normal physiological pattern and rhythm of motility. That is most important. So what are the prokinetic drugs which are available in India? We all know the drugs which are available in India. So we are using all of them. Acoshamide, cinetapride, cisapride is banned, domperidone, erythromycin, etopride, levosulfuride, metoclopramide, mozapride, and prucalopride. All of these drugs are available. Cisapride has been banned since 2011 because of serious cardiac side effects. And most of these drugs have been approved for either functional dyspepsia or gastroparesis, and some of these drugs have also been approved for use in vomiting, and this is the FDA approval, the Indian FDA approval. So how much of prokinetics are Indian doctors using? They are very commonly used. The most commonly used drug is domperidone, but unfortunately almost 50% of patients who you are prescribed any kind of prokinetic have to have adverse effects. Majority of them adverse effects are mild. They may be anorexia, fatigue, and non-serious. But 30% of adverse effects of prokinetics can be prevented by if we are giving the right drug for the right duration and the right dose. So that is where choosing the right drug is very important. So what are the classes of prokinetic drugs? Predominantly are dopamine antagonists and H2 agonists. The dopamine antagonists are the metoclopramide, domperidone, etopride, cinetapride, and levosulfuride. And most of these drugs have effect on the lower esophagus, sphincter, stomach, and some of these drugs have also effect on chemoreceptor trigger zones. So the drugs which have effect on chemoreceptor trigger zones can act as antiemetics also. And these drugs are, as you can see, they are not just acting on the dopamine pathway. Some of them are acting on the serotonin pathway also. Etopride is acting on the acetylcholine esterase enzyme also. So they have multiple mechanisms of actions, and these are related to their efficacy as well as to their adverse effects. The serotonergic agonist drugs are mozapride and prucalopride, which predominantly act on stomach. Prucalopride has more action on colon, but it also has action on stomach. So it can be used in dyspepsia or gastroparesis also. And acoshamide is not a serotonergic drug, but it's a novel acetylcholine esterase inhibitor. So basically what this does is in the muscarinic receptors in the small intestine and stomach, it causes prevents the degradation of acetylcholine at the receptor site. So more acetylcholine is available so that the muscle contraction is increased. It is also a blocker of the M1 and M2 receptors. These are autoreceptors which prevent release of further acetylcholine. So these receptors are blocked, so more acetylcholine will be available. So we briefly look at all the prokinetics which are available. The oldest prokinetic available is metoclopramide, but it crosses blood-brain barrier, so it has lot of central nervous side effects, and it also causes potent prolactin stimulation in males and females both. So it causes a lot of side effects like anxiety, drowsiness, lethargy. In almost 30% of patients can have serious CNS side effects like extrapyramidal syndromes, depression, dystonia. Because of hyperprolactinemia, it can cause gynecomastia, neuroleptic malignant syndrome, and if they are used more than 12 weeks, it can cause Parkinson's-like syndrome. So this drug is not to be used lightly. It is a very drug prone to a lot of side effects. Then the next drug which we commonly use is domperidone. Fortunately, it does not cross the blood-brain barrier so well. So extrapyramidal side effects are less with domperidone, but it is a potent stimulant of prolactin. So it can cause side effects of hyperprolactinemia like galactorrhea, amenorrhea. In males, it can cause impotence. So it is very careful. If the patient comes back to you saying that he is having impotence, we should know that domperidone is causing it. It also has cardiac side effects. That is why this drug is not available in US, because what has happened in US is it is a potent stimulant of prolactin. So young females were being given domperidone to promote lactation. Young mothers who were not producing breast milk, they were given them domperidone to promote lactation. But unfortunately, in these young mothers, they had prolonged QTC intervals. So there was a sudden cardiac death, and that's why it was banned in US. So it is not available in US. So again, we have to be careful in using domperidone in elderly patients, because the cardiac side effects are more in elderly and more in doses if we use more than 30 milligrams per day. But most of the times we use 20 milligrams or 30 milligrams. So if we are using a dose more than 30 milligrams, we have to be careful, and also in elderly. So that is most important. Again, domperidone can cause drug interaction because it is a CYP3/4 inhibitor. Coming to etopride, it is a D2 antagonist, but it also has effect on acetylcholinesterase. So multiple sites of action, good oral bioavailability, no significant drug interaction because it is not metabolized by CYP450, increases GI peristalsis, LES pressure, stimulates gastric motility. It also accelerates gastric emptying and improves gastroduodenal coordination. So there have been multiple studies in which etopride has been used predominantly in functional dyspepsia. The problem with all studies with prokinetics is that the effects are modest. As you can see, the response rates as compared to placebo or standard treatment was around 63%, etopride was 73%. Statistically significant, but the effects are modest. And whenever meta-analysis have been done, what has been found out that most of these RCTs did not have very high standard RCTs. So the evidence for effect of prokinetics in functional dyspepsia is not very high quality evidence, but it's still there because we don't have much other options. Again, a meta-analysis has shown that as compared to placebo and domperidone and mozapride, etopride was better. Usually the benefit with etopride is that no CNS side effects, no cardiac side effects, and no hyperprolactinemia. So that is a benefit with etopride as compared to domperidone or other drugs like metoclopramide. Usually mild side effects like diarrhea, headache, and abdominal pain have been seen. Levosulfuride, again a D2 antagonist, doesn't have good oral absorption. It has good efficacy. In some RCTs, it has shown to improve bloating, abdominal pain as compared to domperidone. But again, problem is that it has a lot of side effects, adverse effects in almost 11% of patients. Again, potent prolactin stimulation, galactorrhea, somnolence, fatigue, headache, extrapyramidal syndrome. Prescription of levosulfuride and PPI combination has increased tremendously, and neurologists are behind gastroenterologists live. You don't prescribe levosulfuride because it is lot of people are coming to them with EPS and Parkinson's like syndrome. There's a study published from South India, published in Annals of Indian Neurology, that has shown that even more than just 2 weeks of use of levosulfuride, EPS like syndrome can occur. And it is reversible if stopped, but 50% of patients, it can persist and progress. So that is a problematic. And as such, if we talk to neurologists, the incidence of Parkinsonism disease is increasing day by day. There are seeing a lot of patients, and some of which may be contributed by use of these drugs. So we have to be careful in using these drugs. Cinetapride, again a D2 receptor antagonist, metabolized by CYP450, non-inferior to domperidone in postprandial distress syndrome. Again, around 10% will have side effects like diarrhea, can cause extrapyramidal syndrome. It doesn't cause any QTC prolongation. So now you know most of the three problems is hyperprolactinemia, CNS side effects, and QTC prolongation. So we have to look at these three. Mozapride is a serotonin agonist. Apart from acting on the serotonin receptor, it improves visceral hypersensitivity. It has effects on colonic motility also. And some studies have shown it has some anti-inflammatory effects on GIT. Adverse effects are mild, dry mouth, abdominal pain, malaise, nausea, diarrhea, but no major side effects. Prucalopride, this is a prokinetic which is approved predominantly for chronic constipation. Again, a serotonergic agonist. Main action is on colon, but has some action on stomach also. So some studies have shown that it gives symptomatic relief in gastroparesis patient, diabetic gastroparesis patient. Again, adverse effects are not very significant. Erythromycin, we all know it's a macrolide antibiotic, but it is also a motilin receptor agonist. Motilin receptors are present in stomach and small intestine. They basically increase the movement of intestine and contractility. So it increases the cholinergic neurons. Dose, it can be given used for hospitalized patients in IV as well as oral. It is more effective than domperidone and metoclopramide, but problem is tolerance. So patients will not have response for longer period of time, and drug interactions also.
Amit, it is IV erythromycin, if I am not wrong.
Yes, sir. IV erythromycin.
And IV erythromycin is not available in India, I suppose. Is it
sir,
available?
It is available, sir.
Is it available?
It is available, sir. Again, we discussed prokinetics for functional dyspepsia, gastroparesis. The controversial is refractory GERD. The dictum is that prokinetics don't work in GERD. So it has not been used commonly, but there are certain studies which have tried to look at whether in refractory GERD, can prokinetics improve the symptoms? So some studies were there, meta-analysis was done. So when prokinetics were added to PPI in refractory GERD, there was greater symptomatic relief, but there was no effect on mucosal healing. So it is just symptomatic relief. And again, similar study which has shown that in diabetic patients with refractory GERD, etopride was better than domperidone. And one of the study has shown that patients who have non-erosive reflux disease, acosciamide plus PPI combination gave a better symptomatic relief. But this is again a controversial and the evidence is not very robust. So we looked at the available prokinetics, their side effect profile, the evidence of efficacy. So just the last slide I'm talking about. So how to choose a prokinetic? That is the topic. So we have to look at the indication. What is the indication why are we using the prokinetic? So we have to be sure that we are treating with either a functional dyspepsia or gastroparesis or GERD. Again, GERD is controversial. So we'll stick to two only, that is functional dyspepsia and gastroparesis. Gastroparesis, we have to prove by scintigraphy studies that there is gastroparesis, and then we can talk. Functional dyspepsia is a clinical diagnosis. Then we have to look at the efficacy of the drug, because patient has come to you for treatment. So you have to give him a efficacious treatment, the treatment which is more likely to respond. So as I said, there is no head-to-head trial. So very difficult to differentiate between efficacies of different prokinetics. But whatever data is available, what we can say is maybe etopride and levosulfuride efficacy is little better than mozapride, cinetapride, and their efficacy is little better than domperidone and acosciamide. This is what I deduce from whatever evidence is available. I may not be correct. This evidence may not be there for long period of time, but this is what I believe. And I think clinically also patient behave like that. They will respond well to levosulfuride better than domperidone. But at the same time, because we have to use drugs for a longer period of time, we have to look at the drug safety also. And a lot of these prokinetic drugs have cardiac side effects, neurological side effects, and hormonal side effects. So we need to use drugs which have least side effects. So etopride and acosciamide and mozapride have the least side effects. They do not have CNS side effects. They do not have cardiac side effects and the hyperprolactinemia. Again, dosage is very important. Domperidone, we should not exceed 30 milligrams per day. And other dosages I had put in the slide, but most of the standard dosages need to be used. Again, duration. If you're using a prokinetic which has EPS like CNS side effects, you need to use for a short duration. If the patient, it is very much required. If the patient is not responding, you want to use a levosulfuride, but use it for short duration and change it to some other drug, because longer the use, more chances of developing Parkinson's-like syndrome. And some of the patients, they may revert, some of them may not revert. So they may become Parkinson's for life. So that is a very difficult situation. So that is what I have to say about how to choose a prokinetic. I thank you all for your patient hearing. And this is a position paper published by Indian Society of Gastroenterology. Whoever are members, they must have received in their email. Most of my talk I have prepared from this position paper only. So it's a very exhaustive position paper on rational use of prokinetic agents in upper GI disorders. So I request everybody to have a look at it once. And thank you all.
Wonderful talk. Thank you.
Did you come running, Amit? Did you come running from Amravati?
I hope I could.
I must thank Amit and Pankaj, both those who have taken a lot of pleasure, a lot of pain from coming from Amravati for this just a small meeting. I must admire them. One thing is, whatever side effects of prokinetics are there, they don't come to us. That's the main thing.
Yes, yes.
They go to neurologists because they have neurological symptoms. And actually, in fact, I'll tell you, one of the senior practitioners from Katni has visited us. A very senior practitioner, very respectable. On his name, there is one lane. So he visited us. And he was taking drugs for such a long time and deteriorated in his mental condition. Levosulfuride.
Oh.
And then, neurologists diagnose it as dyskinesia and the mental problems secondary to this. See, what happens is, the cardiologists prescribe aspirin, clopidogrel, and the GI bleed comes to us.
Yes.
So they are not aware what they are prescribing and what are the side effects of it. So we are prescribing levosulfuride,
so we should
goes
be
to neurologists.
So we should be aware of what we are prescribing.
Actually, it's very difficult. This just a point to be.
Hyperprolactinemia is also a very big problem. It's a very big problem.
They are seen by endocrinologists.
What will be the preferred prokinetic in pregnancy, like hyperemesis gravidarum? So which one is the preferred one for you?
See, pregnancy hyperprolactinemia is not a problem. So whatever is safe, hyperemesis gravidarum doesn't require a prokinetic. It requires an antiemetic. Okay. So any antiemetic can be used. So prokinetic is not required because the problem is not dyspepsia there or gastroparesis is there. The problem is something else. So any antiemetic can be used. And even in lactation, you can use domperidone because that will promote lactation.
Actually, levosulpiride is contraindicated in children below 18, as
Yes.
well as a lot of articles mention that with levosulpiride you should not drive also. So
Actually, levosulpiride is a drug which is approved for psychiatrists. They're using it very frequently in higher doses. It is a very good drug for depression. They use 75 milligrams once a day, and that is a very good drug for depression. And probably that is the reason some of our patients are responding well, because many of them have underlying depression.
Hello.
Yes. Yes. Yes, sir. Yes, sir.
Very nice talk.
Thank you, sir.
My question was, my impression about erythromycin is that it is erythromycin istolate, the salt which is actually useful as a prokinetic, and that
Yes.
is not available in India in the oral form. That is my impression. I may be wrong.
IV is sir available.
Columnar ho jata hai. If esophagus lining becomes columnar, you are more prone to have malignancy. And in the Western countries, there are high incidence of adenocarcinoma of the esophagus because of Barrett's. And in our country also, Barrett's is one of the common cause. There was a earlier belief that अपने country में Barrett's से malignancy नहीं आती है. लेकिन whatever studies have been done have shown that Barrett's same malignancy is a very common phenomenon.
The main thing to produce cancer, thing to produce cancer is the unrest of cells at the junction where the cells pattern is changed. Anywhere in the tubular structures. Whenever there is change in tubular cell pattern, like cervix, like lower end of ureter, like sphincter of Oddi, like gastroesophageal junction, there is change of epithelium. There is always unrest of cells, and there is a formation of cancer. That is the main thing.
Yeah, I think discussions can go on for a long time. It's time to wind up and finish.
Before winding, I must say thankful to Dr. Mukevar. After treating the corona, I appointed only one person in Maharashtra from Nagpur. He has taken the best medicine and distributed it from government of Maharashtra. Because after the corona, there was a black fungus. I appointed only one thing from government of Maharashtra, from collector, and Dr. Mukevar had taken the medicine. भाई 2000 रुपए की मेडिसिन 30,000 में बेचते थे हम लोगों ने फुकट में अवेलेबल करा दिया. बुरा मत मानना, मैं गवर्नमेंट ऑफ महाराष्ट्र से.
Yes. Thank you. We are all grateful to you, sir. Yeah.
Okay, so there was an excellent review on motility, exhaustive review, very detailed and very thorough. So I would like to thank all the speakers who spared their valuable time and prepared in depth for the session. So I'd like to thank Dr. Akshay Kulkarni, Mukevar sir, Amit Gamavandan here, online Dr. Anshuman Nelhans, and Dr. Rajesh Senani and Nikhil Khobragar as well. So thank you for speakers, and thank you audience for coming in and staying till late. And thank you Abbott for sponsoring this event. Thank you so much. Okay, please join us for drinks and dinner. Thank you.